I would like to invite Punjab Chapter President, Dr. Madhu Nagpal, for her welcome address.
Thank you, Dr. Kavita. Am I audible?
Yes, ma'am.
Yes. Good evening, everybody.
Ma'am,
I
actually, we
welcome.
have to play this. Sorry for the interruption. I'll just play this.
Okay.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Yes, ma'am. Dr. Madhu Nagpal, please, your welcome address.
Thank you, Dr. Kavita. Thank you, Dr. Kavita, for all that welcome words. Good evening, everybody, especially the faculty and the audience who have joined the inaugural session, Punjab chapter, today. Thank you, Dr. Sadhana Gupta, for having trust in me to head a chapter, and that's Punjab chapter. Now, expanding the NIGF forum and spreading the knowledge awareness has been always your aim, and for that, Dr. Sharda Jain's efforts need a great applaud. She is the backbone of NIGF with a firm conviction to move ahead in women health spheres, and she is encouraging intensive five-pronged approach. One of them is anemia Mukt Bharat, then cancer cervix free women, then medical legal free practices, and on top of it, spreading knowledge to the specialist and spreading awareness for women at large. Since this is the inaugural session for the Punjab chapter, we chose a subject in obstetrics, which needs a lot of attention, especially the GDM detection and the management. If we know how to detect and we know the prevention will come itself because it has long lasting effects on the future aspects of the mother, child, and the community as a whole. Now, this is all what the speakers will talk about, but I have a few words of praise for Dr. Kavita. She is with me and I have a very pleasant experience because she is very sincere and hardworking. Actually, I tell you, she is doing everything and I'm just stamping it. I'm really and personally of a strong view that younger academicians should be given chance and we should see them blooming. They will surely be more useful to the society and our fraternity for a longer period. But that doesn't mean the seniors are outdated. We are very much the torchlight bearers and guiding them, updating them, and motivating them. As far as my team is concerned, we happily own Dr. Amrit Palkar, who's Vice President NIGF as Amritsar team and a Punjab team. Then the senior most people, Dr. Sushma Chawla. She was 5 years senior to me in college. I have very, very fond memories when she was the outgoing student of medical college and I was the incoming person in MBBS. So I have a lot of respect, lot of tenure together in hostel, out, and then in Punjab. Lot of respects for her. Then Dr. Parneet from Pachala, Dr. Ripan from STRD, Dr. Seema Bhatti from Faridkot, Dr. Chima for PIMS, and Suparna are all the pioneers in our team. My loving Dr. Kavita is already there. She's spoken a few words. She's been very nice to me and she's done everything. I really think that this team has decorated the Punjab chapter very nicely. So today, I'll just thank the speakers for having accepted the invitation and spending time, which is as precious as the knowledge they are going to spread. So sparing time also is very important. So time and knowledge both are being given. So I think they really deserve 3 cheers. I thank the panelists for contributing their knowledge and an important subject. A word for Dr. Ragini. Dr. Ragini, I saw you on the screen and suddenly you're not there. I welcome you specially because you happily accepted to talk on the medical nutrition therapy. I know you are so busy nowadays, probably your election year. All the best to you, Dr. Ragini, for your adventure. Thank you all for joining this meeting. I really wish a good luck. Then more the merrier. We'll see how many people join today. I wish you a very happy learning today. Thank you, Dr. Kavita. You can see.
We तो lectures हो रहे.
पहले तो lecture है.
Dr. Kavita, you can take over.
Ma'am, I would like you to formally invite our chief guest and introduce them also formally, Dr. Sharda Jain ma'am and Dr. Sadhna Gupta.
Okay. It's a very proud privilege to be talking about Dr. First is Dr. Sadhna Gupta. First is Dr. Sharda Jain. Thank you so much for this screen share. She is, I'm very fond of her. I'm a big fan of her for so many reasons. I follow her on the WhatsApp messages and I like very crisp answers and quick answers. Madam, you are welcome to this forum. You are fondly called a teacher of teachers. You are the director, Life Care Center and the Life Care IVF Center. You are founder and secretary general of Delhi Gynecologist Forum, a body of over 2,500 members.
Dr. Nagpal, it is enough.
So I say I love you. And I like you. Will that cover up everything?
That's right. Ma'am, can we have this slide off?
And you are really a guiding force. We are very fond of you.
At the outset, I'm really thankful to Dr. Nagpal and Dr. Kavita, and congratulate you that that Punjab chapter of NIGF has been formed. This is unfolding the galaxy of people across in the northern India. I stand before you with the vision that we unite the gynecologists in northern India, and collectively we transform the landscape of our fulfilling and less stressful path in the competitive world of medicine. Practice today of gynecology is not easy. We face a lot of complexities of medical practice because the medical practice changes every 5 years, and the pressure of patient care and the shadow of medical legal litigations clouding our noble profession. What I feel is we have a vision that we should practice where there's no fear. As time was there in the yesteryears, only recently things have changed completely, and we can achieve definitely this particular vision by fostering supportive environment that promotes mental and emotional well-being. Everybody in the northern India feels connected, and that is why Dr. Sadhna has planned that there is one WhatsApp group where every member is there, and there is one chat group where every member can express themselves. And just in a minute's time, everybody gets connected with any event which is happening. These CME are definitely, bonus because we can update ourselves. And I'm looking forward for a uniform protocols for almost everything, which we can change from time to time. And at the same time, through Kanun Ki Pathshala, we definitely update you what all things you should not be missing it out, because with practice, the litigations are definitely going to come. And lastly, my sincere wish is that all of us must age gracefully and remain active both physically and professionally in our golden years as well. And I think, you people are the invaluable asset as far as India is concerned, and this should flourish. Your talent should not get wasted. And my regards, especially to Dr. Chawla here and all the dignitaries who are here. Dr. Chawla had been 2 years senior to me in PGI Chandigarh, and I have a great regards for her. Madam Amrit, we have been associated in the last 1 year, and I have known her professionally as well as personally. So I think I extend all my regards and well wishes as far as the Punjab chapter is concerned. And here, Madam Nagpal, I wish to tell you, presidents are decorative posts. It is the secretary who has to work, slog and work. So I think you should feel very graceful that you have got people like Kavita to work for you. Thank you very much.
Yeah.
Thank you so much, ma'am. Thank you, ma'am, for the kind words. Your presence helps us to keep us motivated actually to work harder. And Dr. Madhu Nagpal also, her guidance is always there, encouragement. And she has praised me so much, but it is like without her, it would not have been possible for me to hold this event. So thank you so much. And I would ask Dr. Madhu Nagpal to please invite Dr. Sadhna Gupta ma'am for her pearls of wisdom. I'm going to share ma'am's introduction with you.
इसको एंड तक फॉलो करना है ये पेशेंट दोबारा आता है आपके पास कि नहीं मैंने बोला फिर वो UMR नंबर पे हो
I
जाएगा
think I need to have the screen share for Dr. Sadhna. Dr. Sadhna, you're welcome to this forum. I think a few words will express that in last 3-4 years, you have really been so much around us that it looks you are one of us. You're welcome. Your biodata is almost imprinted on our minds. We don't have to tell it time and again. Your efforts have been really too much, and we are with you for every venture. God bless you, and you keep moving ahead. We are there with you. So that is, I think, the best biodata I can say about you, because rest everything is written and it comes every time. So welcome, Dr. Sadhna, to join this. You two together are the main force behind NIGF. You know that. Welcome. Welcome for the evening. Dr. Sadhna.
I think ma'am had joined for some time and then she said she will be joining after 5-10 minutes. So
I think when she comes, we can always read out the biodata. Otherwise,
Dr.
I think
Sadhna is
there
down
no
with
need
viral
to.
fever, and let us see whether she is here. She's down with viral fever.
Okay. I think we can move ahead. When she comes, we can really appreciate that.
So, Dr. Madhu, would you like to invite our
Yes.
guest of honor as well?
I said Dr. Amrit is my own from Amritsar and own from Punjab. So she is part of the Punjab chapter. She is heading the Department of Ops and Gynae, Medical College, Amritsar. She is president of OGS at present. She was earlier the secretary. Then she's acted as secretary for North Zone UFOXY in 2013. She's been the master trainer for PPIUCD program in college. She's been the master trainer for TCTC EMOC program from 2015 to 2018. She is a trained faculty for tubal microsurgery, and she's there in this field for last 30 years with almost 50 publications in her credit, received many awards, and a lot of applaud from all of us. She is the youngest president out of all of us, and she is succeeding our society now. So we proudly have passed it on this society to her, and this is what she's doing. And this is additional that she is vice president NIGF. Welcome, Dr. Amrit.
Thank you, ma'am. Thank you. Good evening to all of you. And my special regards to all my seniors, Dr. Sadhna Gupta, Dr. Sharda Jain, Dr. Madhu, all my seniors and my juniors too. And it's pleasure to see the efforts done by the Punjab chapter under the leadership of Dr. Madhu Nagpal and Dr. Sushma Chawla and Dr. Kavita from Ludhiana. And they have taken the team from all over they have selected from one person from Amritsar, from Jalandhar, from Ludhiana, Patiala, Firozpur, and that's the team effort that they will shine day by day. Every day they will do something good for the society. And it's great opportunity to listen to the stalwarts in the field. Like they have chosen the topics very well, very relevant topics like antenatal screening from Dr. Manjeet Mohita, like the expert in this field. She is our teacher, our mentor. And then we will listen to Dr. Ragni Agarwal on medical nutrition therapy. And above all, Dr. Suparna, the young, enthusiastic, and bubbling with knowledge. She will bombard you with everything how to manage the challenging situations in diabetes. So, with many thanks and wishing the success, and wish many more such webinars to come from our leadership of Punjab. Thank you so much.
Thank you so much, Dr. Amrit. Thank you for
Thank you,
joining us
ma'am.
and
Thank
leading us the way in Punjab as regards to North India Gynae Forum activities. Thank you so much.
Thank you, Dr. Kavita and all team.
So, I have the honor and
I think we go
privilege.
back to Dr. Sushma.
Sorry, ma'am.
We have to invite Dr. Sushma.
Yes, ma'am. Would you like to invite ma'am, Dr. Sushma Chawla,
Sure.
for her?
Always a pleasure to invite her, meet her, greet her, and everything. Now, she's a gynecologist and obstetrician from Jalandhar. Actually, whole of the Punjab knows her. She's a laparoscopist, hysteroscopist, colposcopist, and an IVF expert. She's heading Chawla Nursing Home and Maternity Hospital, Jalandhar. She's honorary professor, ICMCH. She was Joint Secretary, IMA Women Doctor Wing North Zone. She had the founder chapter secretary of IMS and Club 35 in Jalandhar. Then she is a president, Narchi Jalandhar branch. She is honorary professor and dean of Dr. Don ICMCH College.
So
She's
we are all friends.
Yes, we are
We're all
friends.
friends. We know each other. Thank you so much.
I think the best introduction I gave to me, you are my so-called a senior who was an idol in the college. Welcome, Dr. Sushma. I think everybody knows everybody here. So you're welcome to this forum.
Thank you very much. I wish you all a very great success. Thanks, Dr. Shada, for making a good chapter. And I think we together will make a difference. Thank you so much.
Dr. Kavita, you can take over.
Thank you, ma'am. And Dr. Sadhna, if she is joined, maybe we can invite her.
Now you
also.
can welcome her. You can welcome her.
I can see her on the screen, but I am not sure whether she's there. Dr. Sadhna Gupta, ma'am. Hello? I think she's not there, ma'am. Shall we go ahead with the academic session
Yes,
then?
yes. Yes,
Okay.
yes, academics.
I think from our side, we have already spoken, so I'll go on to the academic session now. So
Yes.
I would like to invite our first speaker, and Madam is going to speak on antenatal screening practices so far and the best. So for this, I invite Dr. Manjeet Mohi, ma'am. She's professor and head, Gyan Sagar Medical College, Patiala. And ma'am has worked as a director of medical education research in Punjab, very well-known personality all over Punjab. She's been the director principal of AIMS Mohali, and also headed the Department of Obs and Gynae at GMC Patiala, founder secretary of IMS chapter Patiala, and has been executive member of many organizations, has organized
So that
many
is fine.
conferences and has
continue.
been faculty for national conferences as well. Has written many papers and chapters. Her special interest is in vaginal surgery, oncology, high-risk obstetrics, and medical education. So we welcome Dr. Manjeet Mohi for her first talk on antenatal screening in hyperglycemic pregnancy. So I would like to also introduce the chairpersons for this session. So we have Dr. Ruby Bhatia. She is professor and head of Maulana, that is Ambala, and ma'am is also very, very enthusiastically holding so many conferences and a very well-known personality in all over North India. She's been ex-professor GMC Patiala, Punjab, master trainer for training of the medical officers in Punjab, and has held many positions in various organizations, and she has a lot of papers and presentations to her credit, and has been a vice president of Society of Fetal Medicine as well, and she's been an examiner for all MD exams and DNP exams. And the next chairperson is Dr. Aruna Chaparia. She is the director of Chaparia Hospital.
It's okay, Dr. Kavita. It's okay.
No, I have to formally introduce you to Punjab. So she has been the ex-vice president of IMA Gorakhpur, ex-joint secretary of the women's wing of IMA. She's been the executive member of ISO Park, Gorakhpur, and also been a faculty in many national conferences, master trainer for Dhira and Safe Abortion. We welcome you, Dr. Aruna.
Thank
And
you.
we also have Dr. Surjeet Kaur. She is also very well known in Punjab, a senior gynecologist and a laparoscopic and hysteroscopic surgeon. And she has special training in colposcopy and IVF specialist also. And a very dear friend. We welcome you, Dr. Surjeet Kaur. So with that,
Thank you, Dr. Kavita.
Sharing the screen, and I will invite Dr.
And good evening. Thank you, Dr. Kavita, and good evening to all of you.
Good evening. So,
It's a great honor to be part of NIGF and to be here in GDM.
So over to Dr. Manjeet Mohi, ma'am.
Good evening to everybody. First of all, thanks a lot for inviting me here. It's an excellent chapter which has been started, and I thanks Dr. Sadhana to start it and taken in good initiative. And Dr. Kavita, please, you will have to play my slides. I hope I'm audible.
Yes, ma'am. Yes, Dr. Mohi, you're audible.
Dr. Kavita, you will have to share my slides. I'm sorry.
Ma'am, your slides are coming as corrupt in my mail.
Don't say.
Yeah, I'm unable to download it, but I'll try it again.
I've sent you in through my Gmail.
I've sent on WhatsApp also, so that will be easy.
WhatsApp, it is not coming. I've sent it through the WhatsApp. WhatsApp, it is something else is coming. I've tried to send it through WhatsApp.
It's not opening in my mail, ma'am.
What to do? You tell me. How can I tell it?
Send it to me also, ma'am.
Okay.
On WhatsApp. I try from my side also.
On WhatsApp, I don't have your WhatsApp.
Yeah, you just called me on WhatsApp, ma'am.
Okay, I'll just see.
99 number.
Just hold on.
411 last.
I know Pranjal is here.
Yeah,
It's very difficult. You should have one. Pranjal, what is your number?
9970, ma'am. You just give me a missed call on my WhatsApp. 411, ma'am, last.
Speak again. 99
7025
7025
1411.
1411. It is not. It will not come there.
प्रांजल आप अपना ईमेल भी भेज दो.
यस मैम, मैंने मैम को जस्ट मैसेज किया है.
मैंने भेज दिया आपको.
Dr. Ruby, as a chairperson, you make a comment, so at least monotony is broken.
Yes. Am I audible?
Pranjal?
Yes.
Yeah, yes ma'am.
Please check.
Yes ma'am, I'm
Yes.
just checking that.
It is opening.
I think the topic,
It is
yes, the
opening.
topic chosen today is of utter significance because as we see our wards, every third patient is with gestational diabetes mellitus, and the incidence is increasing
Yes,
as high as
Pranjal, it is
15 to
opening on your WhatsApp.
20%. So what I will say and what our
I've
national
sent it to you.
guidelines say that we must screen every antenatal case on the first visit with a simple test of 75 gram glucose, irrespective of a fasting status, and then take a 2-hour sample. And if it is 140 or more, then more than 140 milligram per deciliter, we should treat her and manage her as gestational diabetes mellitus because the maternal and fetal complications due to gestational diabetes mellitus are so high that it leads to very high perinatal and maternal morbidity and mortality. It not only increases the incidence of congenital fetal malformations, but it also increases the incidence of life-threatening complications like imminent eclampsia, polyhydramnios, malpresentations, urinary tract infection, and indirectly anemia also, obstructed labor, macrosomia. So this is a topic where we all need to have a consensus, and every patient, rich or poor, on the first visit must be screened for gestational diabetes mellitus. And we all should be very clear that unless patient has a slip that she is a known diabetic, if she is tested in pregnancy for the first time, we have to call her gestational diabetic.
जाना नहीं है. Dr. Ruby?
I think, yes, ma'am.
It is not opening. Can I speak as such?
I think that will be good enough.
I think I can speak.
Dr. Sadhana Gupta has joined. We would
Yes,
like to hear
ma'am.
from her. Good evening, ma'am.
Good evening, Dr. Kavita. And actually, this is very, very important day when the North India Gynae Forum, which has been incepted around 1.5 years ago with the great effort of Dr. Sharda Jain, Dr. Ragini, myself, and all the leaders of North India, that today we are having the inaugural academia program of the Punjab chapter of North India Gynae Forum. So that is a way ahead. And in this short span of 1.5 years, we have come across, we have known each other, and a lot of potential right from the very youngster to the faculties and the heads of the teaching institution of North India, we have really come a long way in this very, very short period. So today, very aptly taken by Dr. Madhu Nagpal, Dr. Amrit and Dr. Kavita for the gestational diabetes mellitus, because this is the way, because Punjab and especially Punjab, it is a hub for, it is a prosperous state, and that is coming, it's like a own share of the diabetes mellitus and the gestational diabetes mellitus. So this is the actually aim and the mission of the North India Gynae Forum, that we take up our state issues at the main platform and we find our solutions to the challenges. It is not the Western world which can teach us. So hearty congratulations, and it is very, very important day, and my all gratitude and my all regards to Dr. Sharda Jain, my sincere regards to Dr. Agini, and our Vice President of the North India Gynae Forum, Dr. Amrit Pal Kaur, and our Dr. Madhu Nagpal, a very, very long association. I think a long ago she has come to Gorakhpur and visited Ayodhya when we have only one jet flight. And this is how our relations go. My regards, Dr. Sushma Chawla, to a wonderful person, dynamic, dedicated, loving, graceful, and a dancing. What she teaches us, that all the spirit of the Punjab with all the grace that it makes us very happy. So hearty congratulations to all office bearers, and Dr. Madhu, Dr. Amrit and Dr. Kavita has made their own executive also from the Punjab, and we look forward to great programs and the great contribution of Punjab chapter of North India Gynae Forum. Just I wish to at this moment want to communicate that we have finished one clinical survey on the practices in anemia. We are at this time we are continuing with the practices for the prevention of the cervical cancer, which is again one of the mission which Dr. Agni is looking forward for this particularly. And please contribute, and we are going to have the next NIGF on anemia and pregnancy. So all teaching person who are interested in academic writing, not only the teachers, yes, of course teachers, but all the clinicians who are interested in academic writing, please contribute to these academic write-up of the North India Gynae Forum. And with this, I appeal that we all make more and more members for the North India Gynae Forum, and we look forward to very, very strong association and the presence of North India Gynae Forum at national front. So thank you very much, and I regret a little bit delay, and please go ahead with the programs. Thank you.
Thank you, ma'am, for your blessings. And in spite of being not so well, you could join us. We are so happy to see you and hear you. And Dr. Sadhana ma'am has always been pushing me, date fix karo, topic fix karo. Without ma'am's guidance, and this again would not have been possible for us for this inaugural webinar. Thank you so much, ma'am. And shall we move ahead with the academic talk, please?
Hello.
Dr. Manjeet, if you're ready with your presentation.
I'm just going to, because it is not being opened anywhere. So I'm going to start as such. I hope there is no problem. I'll share my PPT at the group. Kavita?
That will be grateful. That will be grateful.
Okay. So screening of GDM. It is, and basically Alvin Toffler has said that illiterate of 21st century will be those who cannot read or write, but those who cannot learn, unlearn, or relearn. This is very important. So how do we define gestational diabetes? It is defined as a diabetes diagnosed in the second trimester or the third trimester of the pregnancy, provided that overt diabetes was excluded before pregnancy or at least in the early pregnancy. Gestational diabetes mellitus is defined as carbohydrate intolerance of variable degree with onset of recognition during the pregnancy. There is a definitive increase in the gestational diabetes in the past 2 decades as the age of onset of diabetes has been declining, and at the age of marriage and childbearing is increasing. A large fraction of women are expected to enter the pregnancy with pre-existing diabetes, thus creating a vicious cycle in which the diabetes begets more diabetes. The incidence of diabetes in India is global public health problem, complicates nearly 4 million pregnancies of 25 million pregnancies in the India. Incidence is expected to increase about 20%. So 1 in 5 pregnancies will be affected in the near future. The impact of diagnostic criteria for gestational diabetes on its prevalence. How to note about the prevalence? Prevalence will be basically recorded as the GDM, as the screening method that we are using, depending upon type A or type B. So absence of a universal gold standard for screening of GDM has led to heterogeneity in the identification of GDM, thereby impacting the accurate estimation of the prevalence of GDM. If we go by DIPSI, it will be 1 in 6. Using the criteria from 51 population-based studies, pooled overall prevalence was 4.4%. But if we are using IADPSG criteria, then it was about 10.6%. So changing the diagnostic criteria of GDM over the last quarter of a century has led to a significant increase in the incidence of the GDM. Why do we want to screen? All of us know in the mother, polyhydramnios, preterm labor, eclampsia, short term these are, and babies, large for babies, hypoglycemia, hyperbilirubinemia, RDS. And long term, we know that diabetes, metabolic syndrome, CVD, and in the babies, childhood obesity, IGT, over diabetes, dyslipidemia. And if it is a girl, she will also have GDM in the future when she'll become pregnant. So what are the challenges in the GDM screening? So there is an ongoing lack of consensus regarding the screening and the diagnostic approaches for GDM, with inconsistency mainly focuses on the appropriate timing of screening process, 1-step or 2-step, the use of risk factors based approach, and different diagnostic criteria for OGTT. So there is an article for effect of different types of diagnostic criteria on gestation diabetes on the adverse neonatal outcome. So outcome which we want to note about is the macrosomia, hyperbilirubinemia, RDS, neonatal hypoglycemia, NICU admissions, preterm birth, birth trauma, significantly higher than the non-gestational diabetes counterparts. So magnitude of the risk was not different among the women who were diagnosed GDM by more or less intensive strategies. So GDM can be diagnosed by ABCD, and the effect on the baby is not going to change. Now is when to start the screening. Initially, as we know, we used to do it 24 to 28 weeks. But now we are doing it in the first trimester, or at least whenever patient comes at the first visit to us. DIPSI recommends repeat, if first is negative, repeat at 24 to 28 weeks, and then again between 32 to 34 weeks. Then need for testing glucose tolerance in early weeks of pregnancy. The cross-sectional study which has been done in India, they have diagnosed that they are able to diagnose 1/3 of more GDM cases if they do the testing in the early first trimester. So early test advantages, it should be a standard practice. So evidence many women, they will manifest hyperglycemia in the early pregnancy due to the undetected pre-existing diabetes and the higher level of the insulin resistance. So, and whom to be tested? Initially, as far as we are doing as universal, but still some people they discuss that we should do it as a selective screening versus all. So various studies, they have shown that the risk-based approach misses 5 to 45% cases of the GDM, and there is no clear consensus on which risk factor is to be taken. One argument of selective screening is that women detected only by universal screening, usually they have a milder form of disease with a similar outcome. Means a female who is not having any high risk, they'll be having a milder form of GDM as compared to the females, those who have got a risk factors. So in the Indian context, screening is essential in all the women. As the Indian women, they have 11-fold increase in the developing during the pregnancy compared to the Caucasian women. So GDM screening, how to do it? So we have got few things. Number one is the fasting plasma glucose, HbA1c, clinical prediction model, biomarker, plasma glucose after a glucose load, and single step or the double step. So fasting plasma glucose. So Belgian cohort, they have showed that if the fasting plasma is between 91.8 to 99 milligram in the early pregnancy, it is associated with the more NICU admissions as compared to where the fasting blood sugar is less than 91.8 milligram percent. Only 37% of the females with the fasting plasma glucose between 91.8 to 99 milligram, they develop GDM as per the IAD PSAG criteria. French study recommends a threshold of 5.5 millimole, which is 99 milligram, for starting GDM treatment, as it was associated with improved pregnancy outcome. So whenever somebody, if it is getting fasting plasma glucose, so we should take a cutoff at about 92 milligram percent. There should be, our suspicion should rise over there. So if the fasting plasma glucose between 24 to 26 weeks is more than 92 milligram, it should be diagnosed as GDM. So there is a one thing more, is rule in and rule out approach. Rule in is that whenever the fasting plasma glucose is more than 92 milligram, it rules in GDM of about 28.9% with 100% specificity. Rule out is if plasma glucose is less than 79.2 milligram, it rules out GDM in 21.7% female with 95% of specificity. So this is very easy. With this, we can decrease the load of our doing OGTT. This is one, is the fasting plasma glucose. Second is the HbA1c. So HbA1c, as we know, more than 5.9 is identifies women with a high risk for adverse pregnancy outcome, independent of the GDM diagnosis later in the pregnancy. So HbA1c can be used to screen for overt diabetes, but has an insufficient sensitivity and specificity to use it as a diagnostic criteria for GDM. HbA1c could be used as an adjunct to routine testing, identifying those with values between 5.9 to 6.4%. Clinical risk prediction models, suppose somebody says that I want to take it as only in the risk cases suggested by authors, that a history of GDM, glycosuria, diabetes, age, preconceptional dyslipidemia, ethnicity, all of these things, but still they are not agreeing with this. Then we have got some biomarkers these days. So one such promising biomarker is the plasma glycosylated CD59. This is a cell membrane anchored complement regulatory protein that protects cells from complement mediated damage. Single value of PGCD59 between 24 to 28 weeks identifies with a GDM with a high sensitivity and specificity, and it gives an idea of the large for gestational age babies. Study before 20 weeks accurately predicts the results of the OGTT. So this is something which is coming in. Then is the timeline for GDM screening. I'm sorry I'm unable to show, but there was an excellent chart which I have made. So in 1964, O'Sullivan Mahan came and they gave the GDM diagnosis with any of the two values which are not meeting. Fasting is 90, 1R is 165, 2R is 145, 3R is 125. This was the first one in 1964. It was the first diagnostic, but it was only based on the future developing diabetes and not on the adverse perinatal outcome. And multiple samples were to be taken. Then O'Sullivan came himself. It was in 1973, means almost about many years after that. He gave the first, introduced the universal 50-gram challenge test, GCT, and cutoff was 130 milligram percent for all pregnant females. This was sensitivity was about 79%, specificity was about 87%. And the positive predictive value and negative predictive value, they were quite good. And this is the first step which has been taken by the two-step people. In 1979, the National Diabetic Data Group came. They said that a GDM will be diagnosed if any of the two values are not meeting. Fasting 105, first R 190, second R 165, third R 145. Again, they use the plasma instead of the whole blood, which was being used by the O'Sullivan and Mahan. Disadvantages, again, multiple samples and not poorly compliant. Then in 1982, Karpan-Costin criteria came. In this, again, GDM will be met if two more values are not met. In this, fasting was 95, first R was 180, second R 155, third R 140. It was specific to the enzyme assay used quantify glucose instead, and this has lowered the O'Sullivan cutoffs. Disadvantages, again, not based, multiple samples are being used. Then in 1999, WHO came in. WHO said that the GDM will be diagnosed if 2 R value has met or exceed. Pregnant woman will come in the fasting state, and venous plasma sample will be taken after 75 gram of the glucose load, and 2 R sample will be taken as 140 milligram percent. Means WHO has only thing it is fasting and 2 R sample after the glucose load. Advantages, it is uniform definition of diabetes for pregnancy and non-pregnancy fasted. Disadvantages, it is based on the future developing diabetes and not on the perinatal outcome. Then in 2006, DIPSI came in. That is a diabetes in pregnancy study group India. They have done a lot of research. We were also part of it. GDM will be diagnosed if 2R value has not met. Irrespective of the last meal, venous sample will be taken after 75 gram of glucose. 2R, it should be 140 or more than that. It is, and this was included in our national guidelines in 2014. Advantages, it is performed irrespective of last meal. Sample is easy, cost effective, and patient is friendly. But it is again based on the future developing diabetes and not on the adverse perinatal outcome. Then in 2010, International Association of Diabetes and Pregnancy group came. They said any of the two should be not met. Fasting 92, venous plasma values taken after 75 gram of glucose intake. First R 180, second R 153. The advantage, it is based on the adverse perinatal outcome. This basically HAPO. International recommendation foster uniformity of in the guidelines. Disadvantages, this is Indians and other Asians, they were not part of this study, HAPO study. So, but it has definitely included the perinatal outcome. Again, multiple samples are required. So what is HAPO study? All of us know about it. It was large, multi-center, multinational epidemiological study of 23,000 females. It was designed and conducted and examined independent association of maternal hyperglycemia 24 to 32 weeks of perinatal outcome. 75 gram OGTT at 24 to 32 weeks was used. Key finding was linear relationship between the fasting, 1R and 2R glucose levels, and a broad range of adverse clinical and biochemical pregnancy outcome. Now, what is two-step screening, which is being used by ACOG, NIH, German guidelines? They take non-fasting 50 gram glucose challenge test, and they follow the limit, that is 130. And if it is wrong, then they do again a OGTT by giving either 75 or 100 gram glucose. And the criteria are followed by the OGTT, WHO or IAP DSG criteria. So with a 140 milligram threshold at 1 hour, sensitivity is about 70 to 88%. And so two-step people, they do first 50 and then they do again the 75 gram glucose testing. Gestational diabetes, as per say in the India, is DIPSI test. It is simple, economical, feasible. 2R 75 postprandial is taken, and more than 140 is considered as a GDM. Now, but there were some questions about DIPSI also. So some people, they have done study on this. Evaluation of 75 gram glucose load on the non-fasting state. This was studied in the Delhi by Dr. Revati Tripathi and group. They said that prospective study they have done 2 gram 70 2 or 75 gram DIPSI test, and then they followed the same female with 3 days later with a standard OGTT test, that is a WHO or by the IAP DSC criteria. They said that there is a lower sensitivity of the DIPSI from the WHO 65% and IAP DSC about 74%, and they showed that about quarter of the patients, they have been missed if we are using only DIPSI guidelines. Some GDM cases, they were falsely labeled as a normal, as it did not account for the fasting hyperglycemia state. So comparison between the other OGTT, they show low positive predictive value for the DIPSI. So DIPSI criteria, it should be reconsidered till further validated. Again, one person has done a comparison of screening for gestation diabetes mellitus by the oral glucose tolerance test done in a non-fasting state. Again, they said that they have examined 1,000 pregnant female attending their ANC clinic in urban and rural in Tamil Nadu. They again underwent the 75 oral gram glucose test in the fasting and non-fasting state. Again, they have said that the DIPSI has got something which needs to be checked. So there is a low sensitivity value for DIPSI. WHO criteria 27.7% sensitivity is less, and specificity is about 97.7. IAPDST criteria 22.6% sensitivity and 97.8% specificity. So 23 out of 83 female identified who have GDM by WHO, they were missed by the DIPSI. 24 out of 106 female which were diagnosed by IAD-PST, they were missed by the DIPSI. So DIPSI test cannot be recommended due to low sensitivity, and fasting OGTT preferred or two-step is preferred. So pregnant females in the community, they are tested by 2 hours, as we are doing, everybody is doing, that we are following the DIPSI criteria. So screening after the bariatric surgery, we cannot give them oral this glucose challenge. So for them, they said that you have to check post-prandial test at least for 3 or 4 times, and you just match the values with that. Then what are the current practices? What our India is following? So a survey was done on among 3,841 doctors, physicians, diabetologists, endocrinologists, and even OB-GYN people. They have participated about 24 states. They have come that majority of the OB-GYN, they preferred universal screening. In the first trimester was performed in 67% of them. 36.7% OB-GYN and 29.4% of diabetologists, endocrinologists, they reported of using DIPSI method, whereas IAD-PSC criteria was followed properly by 18% and 19% of the physicians. Postpartum oral glucose tolerance testing was advised in 56% by the diabetologist and 71% by the OB-GYN. So more than half of the physician, diabetologists, endocrinologists, and OB-GYN in India, they do not follow any recommended guidelines for the diagnosis of the GDM. This emphasizes the need for increased awareness about the screening and diagnosis of the GDM, both among the physician and diabetologist and endocrinologist. So take-home message from my side is the importance of identifying GDM early cannot be overemphasized. As soon as patient comes, we should do the screening. Screening for GDM is in most setting is shrouded in controversies. The DIPSI method with its limitations seems to be suited for India, especially in the public sector. And IAD-PSSG criteria, though followed by many international organizations, it needs more Indian trials to determine its utility in the Indian setting. New research on fasting plasma glucose and biomarkers is interesting and it should be noted. Generating awareness among the medical professionals and keeping health care providers and the practitioners abreast of ever-changing advances in the key optimum GDM care for our pregnant females. Thank you. Sorry for not sharing the slides. I'm sorry. Hello.
Thank you, madam. Thank you so much. It is our pleasure to listen to you.
It was really pleasure.
Great and very clear.
I will share my slides in the group because I have made them nicely, and so many things which have even become clear to me after reading a lot about it.
Excellent presentation, Dr. Manjeet. It could have, like, without the slides, you could convey a very clear message, and all the dilemmas which we have in the routine in the screening and the methodology, and a wonderful update about biomarkers. Excellent. It was really
Thank you.
Great to
Thank
listen.
you, ma'am. Thank you, ma'am.
Thank you, Dr. Mohi.
Thank you.
Very, very nice update, and you revised our GDM with new guidelines. Thank you so much, Dr. Mohi.
Thanks a lot.
Thank you, Dr. Manjeet, for such an excellent talk.
Thank you.
And whatever guidelines we follow, the importance is that everyone should be aware that patients should be screened at early as possible so that adverse outcome of pregnancy due to diabetes can be avoided.
So, any other comments from the chairpersons or any of the faculty? Or shall we move on to the next talk?
Yes, one message I would like to give, that many prescriptions, what we come across from the periphery, and they usually do fasting and postprandial sugars in pregnancy. And if they are normal, they do forget to many cases come. There is no glucose challenge test done in those cases. And what I feel, wherever it's GDM, majority of the times, and it may, the normal fasting may not predict that this patient can be GDM. So there is no need of doing a fasting. It should always be with a glucose load. And every one of us, even at the smallest center, must make a habit to test for GDM at the first registration visit and repeat it at 24 to 28 weeks. In fact, I repeat in all high-risk cases, wherever I have polyhydramnios or previous stillbirth, I repeat even in third trimester. Though that's not recommended, but I do it.
Dr. Ruby?
Yes,
Dr.
ma'am.
So
I
here,
just wanted to-
here I wish to tell you that there was a case came in National Medical Council, and this gentleman, from where he came to know that the FOXI recommendations are that if you miss out on the first trimester, you must screen in DIPSI in the second trimester, and then if it fails in the third trimester. And this lady had a stillbirth, you know, she was a booked patient, she had a stillbirth, she was seen one day before, ultrasound was done, everything was done. But the day when she came with the stillbirth, the random blood sugar was 208 and the baby was 3.9 kg. We could not save her in National Medical Council also, doctor. So the litigation can come as a result of the same also.
I just want to convey one thing to everybody, that you do as soon as the patient comes to you, first time.
Yeah.
Second at 24, if it is negative, then 24 to 28 weeks. If it is negative, then 32 to 34 weeks.
Correct.
Please make a routine. Please make a routine to save all these undefined fetal deaths. It is very, very important.
In fact, we'll be glad to know that the stillbirths have markedly decreased since the time we have started screening 3 times, you know, in case if it is negative.
Definitely.
But what I was surprised that the case came in National Medical Council and we could not save her.
So this is a lesson for us.
34, 36, and I will say, just to add, that whenever we find ultrasound finding of any polyhydramnios, any large folded, this is the time that we should recheck. With the diagnosed GDM and the treated diabetes mellitus, also we can have the stillbirth. That is the thing which is again an issue, that how the higher, faster, what Madam Dr. Manjeet have said, that the higher fasting blood sugar level is associated with unexplained stillbirth. But what Dr. Sharda Jain Madam is saying, that if we have not taken effort to document diabetes and the treat, that is important. Otherwise, even in the treated GDM and with all the things, we can have unexplained stillbirth, and that is again a very, very close fetal surveillance in all cases of the GDM as well as the diabetes mellitus. So this is also, we have to, like, if we are on the defense, that we have to say, but if we have not taken any effort to rule out, to diagnose, exclude or confirm diabetes mellitus, then the onus goes to us. So what's your comment about Dr. Sharda Jain ma'am about the unexplained stillbirth?
I also feel that, you know, we must uniformly follow DIPSI guidelines, and in Delhi at least we are following DIPSI guidelines in total.
Can I comment one thing?
Yes, please.
GDM in India and GDM in abroad is two absolutely different entities. Our woman is really more prone to develop GDM because of our ethnicity, and they are more obese, they eat more of the carbohydrate, and they have a more of the sedentary lifestyle. And we have to always put our antenna on that any woman can develop the diabetes, specifically or those PCOD girls and all. And as Madam has said, many a time sugar testing is must, not only at the 24 and 26 and aram se baith jao. I tell my patient, yes, you are going to spend more 200 if you are under my care. I have diagnosed GDM at 36 weeks also. So this is something, a mere 200 rupees in a whole, usme 800 rupees going to save a life. going to save a whole life of that fetus also if she or he born as an undiagnosed diabetes. This is my take when I treat any patient of the GTM or my antenatal patients.
Ma'am, one thing I want to
Ragini, you are very right, because the incidence of diabetes in our country is 1 in 5, while in the Western world its maximum is 5%, because they have a carbohydrate in their diet is 50%, while the Indian diet carbohydrate are 75%. So that makes all the difference.
Ma'am, I want to ask you one thing, please. That whenever we are going for testing, we should always check the lab in which it is being done, because sometimes they are not giving 75. They may be giving either 100 or 50 or whatever it is. So this I have checked in my own hospital, because the lab people, they do not understand the importance of this. We have to cross check that what they are giving you. Please ask the patient. And second thing I have noted, that they usually do not take the proper timings. They can take it at 1 hour, 1.5 hour, 2 hours. They are always casual about it. And we are.
Ma'am, that I think we should explain to the patient. What I do is
that is why only thing, if we gynecologists are aware and able to check it and cross check from our patients, only then we'll be able to diagnose whether the patient is going in a right direction or not. This I have seen in my own hospital many times.
Same is here, ma'am. Same is here. That they the lab people are mostly not aware what are the things to be done, what precautions to be told to the patient. The same we are facing here also. They do not count the 75, how it's counted. They do not remove properly, and they don't tell how to take it, in how much time to take it. And if
Madam, can I comment one thing more?
Yes, ma'am.
In the most of the recognized higher lab, they have a 75-gram packed glucose now, number one. To see your lab has followed this. Number two, we have to write anhydrous glucose 75 gram. If patient is taking glucon D, it is a hydrous glucose and it should be 88 gram, or round figure is a 90 grams. So these things we have to take 1 minute to teach our patients, or if you have a very busy OPD, please have a flyer, hand over to the patient, because if they are not coming with the right kind of the report, it is as bad as not doing it. So in my practice, I am very fanatic about the glucose. I call the lab people, I talk to them, and before that I write down on my paper, I give a flyer, because for me this glucose is a very important thing, because not only the stillbirth, it can cause a long-term neurological problem in the baby. If it is a diagnosed baby born to a mother and was not checked by the hypoglycemia, thrown a fit, the whole life of that fetus is gone.
Ma'am, anhydrous is not available everywhere.
Madam, then we have to tell that hydrous glucose, that is
it is a request. It is a humble request, because since I am also a very passionate person about everything, whatsoever I do, and even I have asked to few patients to get it online. But as far as government hospitals are concerned, or as far as even my own hospital is concerned, they are giving simple glucose. It is very
Madam,
clear.
then it is 90 gram. Then it is not 75 gram.
This is what I am saying. The reports that we are getting, are they really good or not? Whether we are missing GDM more or whether we are including more GDM.
But ma'am, 75G is now available. 75G is now
Delhi में अनीता जी दिल्ली में है.
दिल्ली में available है.
दिल्ली में तो available है. दिल्ली में available है.
दिल्ली में available है. We are privileged. We are sitting in Delhi NCR.
I know.
We get it where it is not.
Ma'am, in Patiala, it was never available, and we used to ask them to buy it themselves, take it, note the time, and then go to lab and tell them that please take my sample. And this is what we do now also.
And I wish to have your opinion, everybody, because whenever we talk of screening, we really come across a lot of different experiences. Any your comment, like your experience, that every family, most of the families, even in rural area, have their own glucometer in their home, because unke nana baba किसी न किसी को diabetes होती है. What's your comment that we give the DIPSI if it is a 130, 126, 142? Do you think that if they have the glucometer, they are trained that they can do their own monitoring after taking 100 gram glucose, or if they do
Absolutely, absolutely,
absolutely. Yes, this is something which Madam says absolutely, and you're everyone.
Self-monitoring of the glucose at home is the best way to track your GDM patient. And before that, we have to calibrate that machine also.
Yes. So this is something, because self-monitoring and the self thing is the way ahead, like it is the future of something. So we will like to have all your opinion about it, that it is not only the doctor or lab center, patient themselves can give. And that is the very, very important, because they can check daily, and we will be really sure that what is going on with their blood sugar level. So we can go ahead with the next, Ragi. I think. Yes, yes.
I can only say that the blood sugars is very reliable, and now they are advocating that this glucometer can do it.
यूज करने के लिए मेरी रिक्वेस्ट है, जिन लोगों ने अपने को म्यूट नहीं किया है, एक्टिवली नहीं पार्टिसिपेट कर रहे हैं, प्लीज अपने को म्यूट कर लीजिए, आपकी ओपीडी की आवाजें आती रहती हैं.
I think we'll go on to the next session now, if you allow. So I'm going to share the screen again.
Yes.
So the next session is on medical nutritional therapy. And, for this, I would like to invite the chairpersons.
11th पे आ जाओ एक बार. ठीक है. 11th will be 7, 8, 9.
So the first chairperson is Dr. Madhu Nagpal, ma'am. She's been the head of the department.
Dr. Kavita, please skip mine. Please skip mine.
Okay, ma'am.
डॉक्टर अर्चना सिंह, आप अपने म्यूट करिए. अब मैं मेडिसिन अभी नहीं दे रही हूँ. अब मैं कोई अर्चना सिंह.
Archana, we would like you to please be muted. Yes, thank you so much. The next chairperson is Dr. Anita Rajoria. She is the head of the department of Dr. Hegwar Arogya Sansthan, Government of NCT of Delhi. She is the member of many organizations, has lots of major achievements. She is the president of Delhi Gynae Forum, past chairperson Health Committee AOGD, and she's been the national trainer of trainers for Saath Saath, Lakshya, Daksh. So many honors and awards to her credit, and many, many publications. Dr. Anita Rajoria, we welcome you. And we also have Dr. H.K. Chima with us. She's a professor in Head Department of Obs and Gynae, PIMS Jalandhar. She's the Dean of PIMS, again, Jalandhar. And she's done ACME, that is Advanced Course in Medical Education. She's done a fellowship in International Medical Education and Research. Has many awards, Best Teachers Award, and many international publications as well as national publications, and been a member of many organizations. So again, Dr. H.K. Chima, we welcome you. And I would request the chairpersons to please formally introduce and invite the next speaker, Dr. Ragini Agarwal, ma'am. Dr. Madhu or Dr. Anita, please can you formally introduce and invite?
मैडम आप अनम्यूट कर लीजिए.
Dr. Anita, is she available? No, then okay, I'll do that. Dr. Ragini Agarwal, it's a pleasant duty to introduce you, and every time, should I read out everything or just talk about your social commitments? You are there every day almost, giving some lecture on behalf of NIGF, IMS, IFS, ISAR, then medical nutrition and whatnot. You have so many awards to your credit, but what I say, you are a hot candidate for IMS secretary.
Thank
Should
you.
I wish you
Thank you.
all well for that. I think that's the best wish for you today. Thank you.
Thank you so much, madam. Thank you for your kind introduction. My regards to all seniors and teachers present here, and it's my great honor to share the dais with none other than Madam Mohi, whose name I have heard with so many Punjab friends, and I am able to listen her. Only a master can speak without a slide. So, madam, thank you so much for sharing a dais with me, and my two very favorite person, Dr. Sushma Chawla, the diva, dancing diva icon, and my introduction to Punjab, Dr. Madhu Nagpal. And Dr. Kavita is there, my new young blood from the Punjab movement. We have lots of really focus when the Punjab will come up in the NIGF is like anything, Dr. Kavita. And what to say about the Shada Jain madam? It's very difficult for me to even explain my relationship with her. मेरी दृढ़ाचार हैं और मैं एकलव्य की तरह कम से कम कुछ नहीं तो 32 इयर्स से उनको फॉलो कर रही हूँ, जब उनको मालूम भी नहीं था कि मैं कौन हूँ. Sadhana, a very dear friend, and all here present friends and colleagues, even who are joined as a delegate, I'm thankful to you. Ruby, the Shan of Haryana. So I will start my presentation. Just let me share, because the diabetes in pregnancy is something which very close to my heart. When Kavita has phoned me, I'll say, Kavita, this is something, please don't make me a guest of honor or anything. I really want to speak something, because this is one thing which I did in my practice with my complete heart, soul, and with full mehnat. I give a counseling to every patient, from starting from what is MNT is not how to make your dishes, how to eat a tasty food, and how to continue everything. So this is something is very close to my heart. Thank you, Kavita, accepting my this request that to speak on the MNT. We all know this is a theme of the year is non-communicable disease, and diabetes tops it. And diabetes is one thing which goes to in the generation to generation, from one generation to another generation. And we only can stop if we see our mother, and it was a prophecy, if we maintain the intrauterine blood sugar in 3 generations, maybe the diabetic genes will sleep and we will be almost free of the diabetes. Although it's a hypothesis, but every hypothesis is made with a dream, and it has to come true in few years. I followed Dr. Sasaya, and the type of work has he done for the Indian population. I think we should follow more of him. Not that 50-gram GST in 1 hour in the American guidelines, but the 2-hour 75-gram anhydrous glucose, irrespective of the feeding status after 2 hours. If it is 140, that woman is considered a GTM. So prevention is not waiting for bad things to happen. It's preventing things from the happening in the first place. We all know it is a serious and frequent pregnancy complication with a short and long-term risk to the mother and fetus. As Madam Mohi has said, that still we don't have a unanimous screening, diagnosis, and management criteria. Every health organization has come up with its own. And we all know it is basically an impaired glucose tolerance with onset or first recognition during pregnancy. It may be a DM existing, but if we are diagnosing it first time in the pregnancy, it is a GDM. And we have to follow the guideline of India. Motu chupo jao, please. Oh, Motu chupo jao. in accordance to the World Health Organization, Government of India guidelines endorse 2-hour test. So as I have told you, we have to follow this DEPSI guideline, and it has to be reported at the 24-28 weeks. But if you see that your woman is high risk, she is a case of PCOD, she is obese, a strong history of diabetes, and even at this, when you do the 20 weeks of the ultrasound, the weight of the मैडम iPhone 8437990 या तो आप बोल लीजिए या मैं बोल लेती हूँ ये है
Requesting others to please mute themselves.
Corona, you can do it. So when we talk about the clinical management, we all know the management of the GTM starts from the day when we diagnose it. And medical nutrition therapy is a mainstay. It is the first line therapy along with the physical activity followed by the subsequent 2-hour PPBS testing at 2 weeks, which is maintained below less than 120 milligram per DL. Believe me, friends, it is a real difficult to maintain a sugar less than 120. Even patient is getting an adequate diet, not developing a ketonemia. You have to watch her like a hawk, and you should aware of the diet which you are giving, not a dietitian to send that patient. And if 2-hour PPS is more than 120, medical therapy is added to MNT as per the guidelines. So what we are looking for, this treatment, one is MNT, but is MNT is alone possible? No. We have to put a physical exercise, and as Dr. Sadhna has said, the frequent self-monitoring. These 3 tools are together working. You cannot say I'm doing MNT, I'm not doing other things. And please don't talk all the time the cost. It is not a such big thing when we land up with the problems. And a machine, along with the calibration, along with the sugar charting and maintaining your the medical nutrition therapy, is going to save that woman. Maybe she will not land up with the metformin, she will not land up with the insulin, and she will not land up with a handicapped baby. Physical exercise is something very important. It is, for me, it is a part of the MNT, like a food, like her walk. So, over and above, it is you who is going to make a trust and correct information, make a rapport with your patient. And only a sustained psychological support represent an important part of the therapy, because in our country it is so much eating for the two, eating lots of ghee, lots of sugar, and a bowl of the nuts is so popular. If you set the patient not to eat, the mother-in-law will be angry. Even they will think that you are depriving the woman for developing a proper fetus. So education and counseling before starting the MNT is must, and it is given only by you, not so-called half-educated diabetic educators or the dietitian. We all know that the good emotional state increases the compliance. Stress, anxiety, depression, the nutrition disorder represents some limits, and it is difficult if you don't treat this angle also to come up with the efficient therapy. So you have to individualize. It is not something, it is not like, it is just like a shoe not fit on every feet. You have to see the cultural characteristic of the patient, learning and the decisional capacity. Familial support of the every pregnant woman is very important. Now, a single slide for the physical activity, which is an important add for a successful MNT. You can prescribe aerobic exercises, moderate and mild resistant exercises, for 30 minutes of the physical activity is recommended. Now the patient tell, I'm a working woman, I don't have a time. So the best thing, walk for the 10 minutes before the breakfast, come back, do breakfast and go walking to your office if it is possible, or little bit stroll. And the same will happen the before lunch and before done, and you have done with your 30 minutes of the prescription. So a step to successful MNT is, together with physical exercise, weight control, implementing a self-control strategy should begin as soon as the diagnosis. Should be taught to self-monitoring fasting and the postprandial glucose and keep a diary where to note down the values of the self-measured glucose. This maintenance of the diary or the chart is as important as doing a MNT. Tell her to write down your glucose when you monitor, and when you see it is more, write down what you have eaten and what time you have eaten. So diary should be presented to every visit to the medical team, and you have to evaluate that thing. Give 2 minutes extra. She is here not for a prescription, she is here for the scare. It will help physician to identify the individual variation of the glycemic values, factors determining it, and taking the appropriate decision regarding their lifestyle changes. Maybe a patient is coming with a 150, 160, and you have asked her what she has eaten. She'll tell, कल तो मेरा फास्ट था ना, रात में मैंने 2 लड्डू खा लिए. Because she's not so much, she knows how much it is going to affect her. So these small things only you can check it when she is written in a diary. So what is our aim? FBS should be less than 95 milligram per dl. Specifically, if it is less than 92, it's okay, but between 92 to 95, we have to give a leverage. PP1R less than 140, PP2R is less than 120. I missed a 0, 120. But somehow there's a confusion. Our endocrinologist friend, they say 155. So it creates lots of problem, but we have to stick 95, 140, 120. Write down every time in our prescription, 95, 140, 120. So it has shown that reaching the maintaining fasting the first 2 weeks, implementing MTP are correlated with the reduced possibility of introducing pharmacological treatment. So what are our objectives? Providing the appropriate caloric intake for the both a mother and fetus. It is very important. You cannot be a caloric deficit. Promoting optimal fetal growth. That is another most important thing. Neither microsomia nor the baby should be IUGR. Avoiding ketosis, because ketosis has a long implication of the neurological deficit, and avoiding the mother's excessive weight gain. Nutrition plan has to be individualized, taking into consideration of the mother's particularities, and medical team being the one informing the mother about the risk this condition may have upon her and the fetus in order to maximum compliance. Madam Nishigar and adherence. So it is of most importance for the management of this condition. Can anybody confirm Mrs. Dr. Nishigar not to speak? As studies show that 70 to 85% of the pregnant women diagnosed with GTM obtain and maintain glycemic targets only with MNT. So now coming to the calorie intake, weight loss during pregnancy is not recommended. It has to be balanced weight. If the calorie restriction is required, it should be performed in a controlled manner, taking the consideration the fact that the severe food restriction may lead to a rapid turn of the body using fatty acid and glucose saving. Negative effect of the maternal ketonemia is being associated with the neurological disorders and the future cognitive deficits in the baby. Maternal hyperglycemia induces an excess of the nutrients in the fetal bloodstream, which causes macrosomia and its complication during delivery, obesity, and diabetes during the teenage period of the adulthood, which all we know is the adulthood disease which we are going to develop in utero. So high percentage of the overweight and obese women at their reproductive age nowadays. It is very important to intervene on the woman lifestyle, conducting information campaign, aggressively fight obesity before conception in order to provide a healthy start in the life of future generation. Regarding overweight and the obese women, moderate and calorie restriction is indicated. A reduction by approx 30% of the calorie intake prior to pregnancy, taking into consideration It should not be 1600 kilocalorie per day. So when we see the chart, there's a BMI is less than 18.5, that is underweight, calorie intake 35 to 40 kilocalories. 18.5 to 24.9 is 30 to 34 kilocalorie per day. Overweight patient is 25 to 29, and obese patient should be not more than the 25 calories per kg per day. Government of India guidelines says energy requirement does not increase in the first trimester. Energy required only during the second, third trimester. And as per Indian ICMR guidelines, average weight of 10 to 12 kg and the 350 kilocalorie per day is enough. This equation is given by them is the energy requirement is BMR into physical activity. BMR is basal metabolic rate and the PL is the physical activity level. So BMR for adult is 14 into weight plus 471, and she is more than 30 years, then 8.32 weight plus 788. And PAL value is given as sedentary work 1.53, moderate work 1.8, and heavy work is 2.3. So you put in the formula and you can find out, although it is very, very difficult to do. So a woman with a PMI less than has to a target weight between 11.5 to 16 kg, underweight 12.5 to 18 kg, but if she is obese, 5 to 9 kg is more than enough because she has lots of fat which can give the energy. Now the idea of the carbohydrate dietary restriction in GDM has its origin even before the insulin era. It was found that it prolonged the life in women with the type 1 diabetes and reduces the stillbirth. There's a numerous study which correlate. In 1990, it was proposed as a first-line treatment of the GDM, but today it was an emphasis on the identifying the most appropriate type of the diet that provide optimal results. In 2018, a meta-analysis has given that a nutritional intervention led to decrease of the fasting glucose by 4 milligram, PP by 8 milligram, and birth weight is by 171 gram. There's numerous controversy again for the optimal intake of the CH. So now the proposal is go for a low glycemic index. Glycemic index is a value assigned to food, and complex starch with the low glycemic index should be preferred. Low GI, we have seen that it is all those vegetables and few fruits and the dairy products and the whole grain, not the processed food and the simple starch. Medium is banana, couscous. Here, I have why I have taken this group, because this is not okay. When you just write a pizza, you are not very writing which pizza. In India, we get the maida pizza, but in abroad, in the Italy and all, it is a whole wheat pizza, and that whole wheat is not the engineered wheat which we are using. They are using a durum wheat or a old grain wheat, which is not such a high index and like a simple starch does not have. So we in India, when we are talking about these things, we have to be very, very particular what we are going to tell them, and our most of the patients are not so educated, not so well affording. So we have to be very restrict and very clear what we are going to advise. A minimum quantity of the 175 gram of the carbohydrate per day, representing 35 to 50% of the total calorie intake. This is the glycemic index chart, which is not even being seen to me. So quality and the distribution of the carbohydrates should made according to the particulars of every pregnant woman. You have to see the BMI, weight gain during pregnancy, fasting, and the postprandial glucose value, presence or absence of the ketonemia. It should be 3 main meals and 3 small snacks. You have to tell your patient at least during the pregnancy your diet should be start with a small snack like a nuts. Then you have to take a breakfast by 8. You have to take your mid snacks 11. Your diet again should be around 2 is a lunch. 4:30 to 5 another snack, and then 8 your major dinner, and by the time you sleep a small glass of the milk or something is enough. Try to sleep early, do a meditation, don't be chippo your social media and see the in the night your phone, WhatsApp and eat something. This is absolutely wrong. But if a patient is GDM, even any patient, it is mandatory when she get up in the night, go to the loo, eat some seeds or something like, so she is not going to have a hypoglycemia in morning. When you calculate, most of the women, they have more than 8 hours sleep, and when they get up, they are little nauseous, they are having dizziness. It is all because of the hypoglycemia. So breakfast should be reduced to 15 to 30 gram, taking into consideration the morning peak of the cortisol secretion, which explains why most pregnant women with GTM present with a high blood glucose values after the breakfast. Numerous studies suggest the diet based on the food with a low GI improve the glycemic profile and should be used deciding a menu for the breakfast. So these are a big group of the vegetable where you can give a fiber also, and the satiety in a form of the carbohydrate. It should be not more than the 28 gram per day, because it was found if it is more than 80 gram per day, the patient has lots of problem. Meta-analysis highlighted the risk of the fetal macrosomia is decreased with the fiber intake. When we come to the protein intake, it is an appropriate intake is crucial. Although there is no evidence that as such it is going to affect the GTM, but it is required because our diet is very, very deficient in the protein. You talk to a patient, they will say that they are taking dal only on the twice a week or thrice a week. Most of us are vegetarian. Again, to give a protein diet up to a 71 gram in a vegetarian is a very, very difficult. ADA recommends a 70 gram per day. We have read that the 1.2 gram per kg body weight protein is required, but some studies are coming that it is a 1.8 gram per kg body weight amino acid should be given, and it will be increased by the 16 weeks. So it has protein source are low fat, white and red meat, eggs, soya, nuts, and vegetables. I'm not a fan of the soya during the pregnancy. We should remember that soya is a estrogenic thing. So we have lots other legumes which we can give to our patient, not give lots of soya to them as a form of the protein. Animal products should be very well and healthy cooked. Fish and seafood is extremely good as omega-3, but remember they can have a contamination. More than 2 helping of the seafood more than the 200 gram is not recommended in a week. Lipid intake, again, a good amount of the lipid intake, but not the excess is must, because when there's a too much of the fat leads to an increased insulin resistance, and the triglyceride and the free fatty acid leads to a beta macrosomia due to the triglyceride hydrolysis and the FFA transport to the placenta to the fetus. A study was performed on 34 pregnant on the dietary approach to stop hypertension, and it was found that HbA1c was decreased. At present, recommendation is 20 to 35%. The saturated fatty acid and the trans fatty acid should remain to the 7%. Even should go for a trans fatty acid is almost negligible. So it is very necessary to tell our patient not to go with this cornflakes, cereals, or all those instant food, Maggie and all. As such, pregnant women are advised to choose meat with a fat content below the 10% and the low-fat dairy products. Remaining percent is divided with the MUFA, PUFA, and the omega-6. Again, this omega-3 and omega-6 ratio you have to maintain. The report between the 3 types of the F is still not clear, but a study highlighting the fact that supplementing the diet kit with the PUFA and 3 omega-3 is reduced fetal macrosomia. So if you see in a nutshell, then the carbohydrate is a 30 to 50%, protein 71 gram minimum per day, and lipids to the 20% to 35% or 30 to 35% with the different societies. Vitamin and mineral intake is another important thing to see because their intake is also increased, and we have to see a varied diet. Diet should have a salad, green salad. Some things in a raw form also should be introduced to these women. Folic acid, we all know it is essential, is a preconceptional vitamin, and after that 3 months it should be reduced to the 4.1 to 1 milligram because it causes the high folic acid also connected with lots of problem even in the asthma in the patient if you continue in the higher uh, RDA after the 12 weeks. Then in some studies they recommend the vitamin C and E also as an antioxidant, but not very studies are there to support it. Then meta-analysis is found vitamin D is really a good vitamin which should be given, and it improvement of the insulin sensitivity and the HbA1c and the glucose recommend dose is 5 microgram per day or 10 micro, or we can say 1000 IU per unit per day. During pregnancy, vitamin A is contraindicated. Calcium is necessary, 900 to 1000 milligram. And it should remember the iron and calcium should not be given together. Calcium is best absorbed in the evening, so we can tell the patient. So there's a difference between the iron and calcium. Iron is necessary, 27 milligram per day. In our women who are very, very anemic, we have to say that by the 16 weeks or 18 weeks, their iron level is very good. If it is really low, go for a serum ferritin and give them the IV iron and maintain the iron. So it was found that the 50% higher risk of the GDM in pregnant women who had an excess of the heme iron, mind it also. So sugar substitute, although FDA say you can take it, but a big no for it because we don't know what chemical is going to affect the baby. If you have a sugar, why not control yourself? Because you are going to have lifetime disease. That's a high time when you are motivated for your baby. You can go without sugar and it will make your life better. You are not going to develop the diabetes and its complication in the later life. So intake of the coffee, alcohol, and smoking is just like any other patient. And always remember, if you want to tell your patient that 200 milligram the caffeine is enough, which is a Starbucks regular coffee cup. Newer direction is the plant-based diet. It is there's a evidence that type 2 diabetes by decreasing gastric emptying, improving insulin sensitivity, and there are new evidences that the suggest diet based on the plant-derived food may have a positive impact on the GDM. It has increased the level of the oxidative stress, inflammatory markers, necrosis factor, alpha, C-reactive protein. They're all modulated by the diet based on the plant-derived food, such as the Mediterranean diet, and it has vegetable, fruits, nuts, seeds, oil, beans, and whole grains. A consideration role in the cytokinins, respiratory syndrome. So it is very good if we talk about this plant-based diet to your patient. Myo-inositol is again one thing which has proven during the PCOD treatment. It's a wonder thing. It is also found that the reduction of the GDM incidence was quoted by numerous studies in the patient who was at the risk of the GDM. So to conclude my talk, GDM is the most common medical complication of pregnancy. Reaching an international consensus regarding the screening, management, and the follow-up for the women with the GDM is of extreme importance. Women with GDM should receive MNT as soon as the possible of the diagnosis, but prevention is of the utmost importance among the pregnant women and women that are trying to conceive. So they need a preconception diagnosis, and the duty of us is just to be more learning for the nutrients and the nutrition counseling. Or by yourself, the chart can be made for your dietitian, but the basic understanding of the nutrition and the diet is necessary for every obstetrician who are specifically doing a high risk obstetrics. Pregnancy represents a special time in the life of every family and should be seen as an opportunity. All the time we talk about the window of opportunity in our practice, whether it is a HRT, whether it is a PCOD consultation, whether it is obesity reduction, whether it is a opportunity to introduce the cervical cancer vaccination. So this is a time also to introduce the proper healthy lifestyle and break the vicious cycle of the unhealthy choice, obesity, and the metabolic syndrome transmitted from one generation to another. In this period of the time, families are more motivated and committed to change the healthy choices. This is the right moment when the medical team may implement efficient prevention strategies for fighting against the epidemic of the obesity and the DM. So treatment without prevention is simply unsustainable. Thank you so much for giving me this opportunity and patient hearing. Thank you so much.
Thank you, ma'am. Thank you for that wonderful presentation. You have covered almost each and every point that is related to medical nutrition and therapy. Thank you for highlighting the importance of exercise, which is going along with MNT. And what is important is I always tell my patients said that suppose you are eating two chapatis in breakfast, you divide them into two portions, one at around 8, as madam has highlighted, and another chapati you can take with lot of vegetables at around 11. So similarly, she can break her meals into 6 rather than 3. 3 major and 3 small meals she should take. And along with that, you very rightly said vegetables and fruits, what portion she can eat is also relevant. Sugary, very sugary, fructose rich fruit, she can have just a slice or something like that. Patient has to be told the conversion table also. Like, suppose to break the monotony, she wants to have pasta, so she should be told that she can have low cal pasta, not enriched with lot of fat. She can replace one katori of cooked pasta instead of one chapati. She suppose she wants to have pasta at 11, she can skip the chapati she was supposed to take at 11, and she can have her pasta. And madam has very rightly said it should be ideally whole wheat, not the maida one. So that way we can counsel these patients and teach them passion, teach them how to bring variety in their food also, because they will otherwise get bored, they will not stick to the medical nutrition therapy. Now, what is to be done after 15 days is also very important. We will ask her that if you stick to this kind of medical nutrition therapy and exercise as advised by obstetrician, it is good. Then after 15 days, we are following them with at least 1 pp blood sugar, which should be less than 120. So if the blood sugar is coming less than 120 after 2 hours of breakfast or meal, then we say that MNT is working. But if now blood sugar comes more than 120, now patient will need some other supplementation, either metformin or insulin. That is a point of discussion we can have in the panel discussion. But MNT, if effective, should be continued even if you are starting pharmacological treatment later on. It's not that once we start insulin or metformin, patient will go back to MNT. MNT has to continue, exercise has to continue, besides giving pharmacotherapy to this patient. Thank you so much, Ragini ma'am. Thank you for highlighting each and every important part.
Thank you, Dr. Ragini, for a very Thank you, Dr. Ragini, for a very elaborate lecture on medical nutrition therapy. I think it stands true for so many conditions. Could be a polycystic girl, could be an obese lady, could be any elderly beyond 50. So the diet nutrition aspects, they remain virtually the same. But very simple to explain the patient that you have short breaks. Try to eat shuddh khana, simple khana. When we say shuddh can be less oily, less spicy, less sugary, and less salt. Then at least it can be rang birangi thali. Like rang birangi, you have lots of vegetables colored, salad, and 1 or 2 chapatis. Then everything in moderate. Don't overeat. Always leave 1 chapati behind, means eat lesser than your appetite. And then if you've taken something extra, try to cover up by not eating too much of it. So I think few tips need to be given to all, including the GDM mothers or pregnant mothers, and for rest of the public also, including me also, should really follow that kind of medical nutritional therapy. Thank you so much for a very, very elaborate lecture.
Thank
Now, I want to
Thank
convey
you.
one thing.
Yes, madam.
Since we are living in Punjab and this is in Punjab chapter, ma'am, our patients, they drink milk and they drink milk, whole milk. They have kept kettles in their house and they take chuama dudh, which is full of fat. So this is a common practice with me. I always ask them, how much milk do you drink and from where do you get your milk? So everybody in Punjab has to be very particular in asking this point because that is containing a lot of fat and they do not recognize it. They will have dahi, they will have chai, they will have milk with that only, and it completes the whole calories even with 2 or 3 glasses of the milk. So this is why
Absolutely correct, ma'am. Yes.
Punjab has to be very, very particular about asking this point. And now,
Yes.
since winters are there, so every house will be having khoya, every house will be having pinnis, every house will be having saag with lot of butter. So Punjab is इसलिए तो diabetes है.
Madam, the only thing can save if you said them, if you eat this diet, your child is going to have
ma'am, this is not.
diabetes.
Only thing is that what I want to say is every gynecologist must ask about it.
Yes.
हम पूछते नहीं, वो बताते नहीं, वो सोचते ही normal है.
मैडम डाइट तो अपने आप करनी पड़ती है पेशेंट की.
This is the one thing which I request every person. Please ask, please, because they accept it as a normal thing. Drinking a milk from pure milk is a good thing for them. This is a common concept.
गर्मी में मैम ठीक है, गर्मी में अच्छा है. They can have छाछ because it becomes skimmed. The cream and makhan goes away from that. छाछ is all right, but hot milk, pure milk, full fat milk is very dangerous.
Punjab is very bad, ma'am. Punjab is very bad.
It is dangerous. They can eat.
Very
They can
dangerous.
eat 100 ml of the
And they will not
full
accept
milk
it.
also.
Excellent, Dr. Ragini. I think in my practice, dietitian and the physiotherapist are part of our team. So usually the dietitian takes about 45 minutes to tell the diet, and the exercise lady, our physiotherapist, another take 45 minutes to make them do exercise. At times, I also do little exercise with my patients just to demonstrate it. So excellent, Dr. Ragini. And it is a written prescription, meditation, diet and exercise. Just put it down, 1, 2, 3. And after that, the medicine.
Even, madam, I write one more thing, that is meditation. That is more important in today's time. They have to stop their social media at 7 so they can sleep, because if they don't sleep properly, it's going to not going to control their sugar. They are bound to eat something in the night also.
One important thing I learned from diabetes people was that they say that in advanced pregnancy, patient may not be able to, walk for long. She may feel the early, tiredness. So you can always, ask them to do upper limb exercises. Even that is important. Even if she's sitting and doing upper limb exercise, it will consume some amount of calories, which becomes very, very relevant, especially in GDM patients. So this is one thing I learned from diabetologists.
One comment, Dr. Sushma Chawla. What you say, 45 minutes for dietitian, 45 minutes for this. For all practicality, it seems very difficult, and I think we should now go ahead with the really implementation of idea of the group therapies, group nutrition and the group exercise, because actually in reality there may be few VIP patients, but actually to give that much of time and how much, because what we are seeing a lot of differences, whole milk, what is, so when the dietitian asks, and the dietitian, and the second thing, one is the group thing, and because it is like a very positive environment, and even non-GDM patient need to have only that sort of diet. And the secondly, the dietitian tend to speak in a different language. So this is very important gap, that we don't speak the language, we don't speak the food, what they know in their thing. So that language barrier and the communication barrier is something our dietitian, हम लोग कैलोरी की बात करेंगे, विटामिन की, लेकिन हमको बहुत स्ट्रेट होना पड़ेगा कि आपको ये चीज खानी है और ये आपके और बच्चे के लिए, चाहे बहुत ब्रीफ, but it should be to the point and it our patient's head and heart. So a group thing is very like something which is doable, especially in institution and as well as the corporate setting where we have a staff and we can tackle with 10 or 20 or 30 patients as well as with their families. So this
I do my nutrition counseling, although I'm working in a corporate hospital. I do my nutrition counseling of each and every patient. I call them for a consultation that is only devoted to a nutrition and the exercise counseling and nothing else.
I mean, this is something what a person have, but to like it is around 10 to 16% GDM in our country. So when we really want to reach the unreached, then these are the few ways that like our experience should lead the way.
How we do our antenatal education classes with all our 40-50 patients in a go. This is very important what you have said, Dr. Sadhna. So I think our panelists are waiting.
Yes, ma'am.
That we should
So
go
that was a
from here.
very informative talk and interesting discussions on medical nutritional therapy. And as ma'am has very rightly pointed out, the panelists and the moderator waiting patiently and very eagerly for the panel discussion. So we move on to the panel discussion, which is on case-based discussion on management and outcomes in hyperglycemia and pregnancy. So for this, I invite our moderator, Dr. Suparna Grover. She is professor in Department of Obstetrics and Gynecology, Government Medical College, Amritsar. She is also the secretary of Amritsar Obs and Gynae Society, straight trainer for PPIUCD, MDSR. She has 14 years of teaching experience and has many publications, authored chapters, and has special interest in high-risk pregnancy and critical care obstetrics. So Dr. Suparna Grover will be taking us through the panel, and I will request Dr. Suparna to please invite and introduce our panelists.
Yeah. Good evening, everyone. Thank you, Dr. Kavita. I hope I'm audible.
Yes, you are.
Yeah. Thank you, Dr. Kavita, for the kind introduction. And it's an honor for me to welcome my panelists. First of all, Dr. Parneet Kaur, Professor and Head Obs and Gynae Department, GMC Patiala. Teaching experience of 21 years, has been an examiner for UGs and PGs for 13 years, 68 publications, 3 chapters in books. She's a reviewer for 2 reputed specialty journals, and she's president of NAPA Obs and Gynae Society. She is master trainer for PPIUCD, and with that, a teacher for me. And then Dr. Seema Grover Bhatti, she is working as professor and head Department of Obs and Gynae, GGS Medical College, Faridkot, since last 9 years. Teaching experience of 19 years as medical faculty. She has completed advanced course in medical education from MCI Noodle Center. She's a member of Medical Education Unit and Ethical Committee of the Medical College, and she's member of Clinical Research Committee of FOXI as well. Recipient of FOXI CS Dawn First Prize at Agra AICOG 2016 and multiple prizes. Second prize for poster presentation at IMS conference in 2012. 30 publications, 2 chapters in book, and special interest in high-risk pregnancy. And she is a co-investigator in an ongoing project to decrease PPH-related mortality in District Bhatinda and Faridkot. Welcome, Dr. Seema. Dr. Poonam Goyal. She is a chairperson-elect for Safe Motherhood Committee 2024-26, ICOG Governing Council member and executive member of AOGD. Currently, she is HOD, IVF and Infertility Max Super Speciality Hospital and Director and HOD OBGY at Panchsheel Hospital, Delhi. Dr. Nishi Garg, Director, Garg Multi-Speciality Hospital, Faridkot, ex-professor, and at PIMS, Udaipur. She has more than 32 years post-PG experience in Obs and Gynae, President KFOGS, Society member.
Move on.
Okay. So many things. And my last panelist, Dr. Vinita Munjal. She is presently HOD Obs and Gynae Services at Shri Guru Tegh Bahadur Hospital, Ludhiana, and professor at Homeopathic Medical College and Hospital, Ludhiana. Formerly was an AP at Christian Medical College, Ludhiana, and she has received multiple awards and honors for charitable and rural services, and has total 25 publications with the 40 articles published in vernacular dailies on obs and gynae ailments. So a very good evening to all the esteemed officials of NIGF and members of Punjab chapter. I extend a very warm welcome to all my panelists. I have representation from the teaching institutes in Punjab and also representation from a corporate hospital at Delhi and private sector in Punjab, which gives us a great opportunity to learn from experienced people from a wide array of obstetric practice on the topic of hyperglycemia and pregnancy, something very, very relevant to our day-to-day clinical practice. Our job has been made so much easy by Dr. Manjeet Mohi's lecture and the lecture on MNT by Dr. Ragini. So we will try to reinforce the messages given by them, but we'll try to move more rapidly towards the parts which are not as yet covered. So I would just start sharing my screen. Okay, I hope everyone can see it.
Yes.
Is it full screen?
No. Make it slideshow. Yes.
Yeah. Okay. So since the clock is tickling, so I think it's time to jump straight to our first case. We just have 2 cases for the day. I would request Dr. Kavita to warn us after 15 minutes so that we don't spend so much time on case 1 that we don't give any time to case 2.
I'll do that, Dr. Suparna.
Okay, so we have Mrs. X. She's 32 years old, G3P2L2, coming for getting her pregnancy registered at 2 months amenorrhea. She had previous 2 uneventful pregnancies with live births, neonates that were appropriate for gestational age, no medical disorders, no previous surgeries, no family history of diabetes. She has a normal BMI, she's normotensive, no anemia, euthyroid, everything normal. This client gives us no reason so far to label her as a high-risk pregnancy. So my question for my panel is, would you like to screen her for hyperglycemia in pregnancy? If yes, why? If no, why? If yes, how and when? We shall start with Dr. Praneeth. Dr. Praneeth? Is she there? Okay, Dr. Seema?
Good evening, everyone. Thanks for giving me this opportunity to be part of this inaugural webinar. All right. So now coming straight to the answer. So whom to screen? So now the answer is that universal screening is required. Universal screening must be done. And when to screen, the answer to when to screen is that at first booking. When the patient comes first, that is the time when, just a second, my phone is ringing. I just need to cut it out. Just a second.
Dr. Praneeth has joined, I suppose.
Yes, I was there. I think I got it.
Okay,
so we have to
please.
screen. We believe in universal screening. We go by DIPSI guidelines. So we have to screen, and we have to screen each and every pregnant female, and that too at her first visit. So we will be screening this female, whether she is having previous 2 uneventful pregnancies. So at 8 weeks, first visit, we have to screen her. We follow DIPSI guidelines, and we do 75-gram glucose test. And irrespective of her fasting status, we give her glucose, and we have to explain her that it has to be taken in 5 to 10 minutes. It is dissolved in 300 ml of water, and after 2 hours, we take a sample, and the test, if it goes beyond 140 milligram per deciliter, then she is positive and she is labeled as GDM.
Ma'am, could you please just justify why screening at the first visit, first trimester, woman is having so much of nausea, vomiting? Shouldn't we be more worried about hypoglycemia than hyperglycemia?
Yes, but it has to be that actually it is seen that if we miss it, then by the time we in later pregnancy, we screen that many females will be missed, and we may not have the time to control her hyperglycemia because that will affect her baby. And so it is, and in Indian females, it is seen that postprandial hyperglycemia is more. So we have to do a postprandial test that will diagnose many of the cases which we have been missed. So it has to be first visit and screening has to be done so that we pick up the cases early in pregnancy. Of course, if it is negative, then we do go for repeat test at 24 to 28 weeks. But the first visit screening is a must so that we don't miss any of the case, because hyperglycemia in pregnancy has much adverse effects on and female as well as her unborn child.
Okay, Dr. Vinita, your take, please.
Good evening.
Good evening. Your take on this, your screening practice.
Yeah, I follow the Government of India guidelines. Just like mentioned by Dr. Paneet, we give 75 grams of glucose, irrespective of the meal status, and that is to be consumed with 300 ml of water within 5 to 10 minutes. And then we do a postprandial blood sugar levels after 2 hours. If it comes out to be less than 140, then we continue with routine antenatal monitoring, again, the routine antenatal checkups, and rescreen again at 24 to 28 weeks. If it comes out to be more than 140, then we ask the patient to go for nutrition MNT, multi-nutrition therapy, and this is to be followed for 2 weeks. So,
okay.
Again,
Any opinions on third screening?
Yeah,
anyone who is going for third screening after 2 negatives?
Third screening, yes, I think it should be done because the insulin resistance, it starts increasing after 20 weeks and it increases till term. It is till 36 weeks. 1/3 screening should be done, especially in high risk groups. It should be done. Or if we see any changes on ultrasound, abnormal weight gain, it should be done.
Yes, Dr.
Yes,
Suparna,
and
if she's missed her screening and her first visit is in third trimester, then definitely we should go for screening. But yes, if we find any of the complications, she's developing macrosomia or her ultrasound shows polyhydramnios, then definitely we can go for third screening.
Yeah, and going by the statistics, it is seen that 33% cases are diagnosed in the first trimester, then 48% in the second trimester, and 28% in the third trimester. So it's better to screen so that we don't miss at any of the steps,
Thank you, Dr. Vinita, for highlighting that. So we are diagnosing as high as 1/3 of our diabetics in first trimester if we are screening that early. And the benefit is that fetal programming that we are so worried about in hyperglycemia in pregnancy, it begins as early as 11 to 15 weeks of gestation when fetal insulin comes in play. So we all know about Barker's hypothesis, how fetal hyperinsulinemia is responsible for macrosomia and risk of adult agehood, obesity, and metabolic syndrome. So when we are talking about addressing this problem at the level of a society, we are talking about improving the general health of the society. The time to intervene is as early as possible in the pregnancy, because once the fetus has been exposed to maternal hyperglycemia in those early weeks, it may actually be too late to intervene. So those in audience who are still not convinced about it being a universal screening and an early screening, I think after Dr. Manjeet's lecture and after these deliberations, there should be no doubt, because in Punjab, we still see patients coming as late as near term with no screening done throughout the pregnancy, and we hope the practice will change. So coming to one step and multiple two-step screening, I think in our setup, in at least for public health setups, the one-step screening is the answer, because once the patient comes to us, this may be the only time she comes to us. She may never be coming back. So I think we are all on agreement as far as DIPSI criteria are concerned, and I really hope that in future discussion we are not so much on agreements. We should have some disagreement so that we can just churn out something new from this panel discussion. So moving on.
Hello. I would like to add something that in first trimester, if we are able to get HbA1c, So we can titrate or we can diagnose the chances of anomalies coming up in the baby. I think that if patient is affording, we can add that test in our protocol also.
Yes, in first trimester, definitely HbA1c has a role in at least telling the patient her prognosis, her probability of having anomalies in the present pregnancy. We'll come to that as we move on. And okay, venous sample or capillary sample, Dr. Nishi.
Yes. So when we are doing this with the capillary, usually we are seeing that it is little higher than the venous sample. So we can tell the patient that this much is the report and we go ahead according to the guidelines which we have got. And once we are doing this DIPSI test, it is the venous sample which we take for the testing. And later on,
Dr. Poonam? Yeah, Dr. Poonam? Dr. Poonam is there?
I think she's not there, Dr. Suparna. She had a emergency, I think. She had told
Okay,
me.
okay. Dr. Praneet,
Can I
at
take
the
this?
GMC, but yes,
Can
yes,
I
yes,
take
please,
this,
ma'am.
Dr. Suparna?
Yeah, please,
So
please.
already, as Dr. Nishi has already said, that capillary blood sugar will be a little higher. It is about 10 to 15 milligram higher than the venous plasma glucose sample. So venous plasma glucose is more accurate. And when the patient is on oral hypoglycemics or insulin, it is recommended that at least once a month before 28 weeks, we should get a lab testing done, that is venous plasma glucose, even though she is doing self-monitoring at home. So once a month, between 28 to 32, it should be done once a fortnight. And then after 32 weeks, at least once a week. So you are making sure that your glucometer readings are correct and you are getting an accurate picture. So that is the importance of venous plasma glucose, that is sending it to a lab versus doing the self-monitoring of blood glucose at home. So
yes, we all have subconsciously more trust on venous levels as far as blood sugar is concerned. But again, Ministry of Health and Family Welfare guidelines, they do allow for testing for capillary blood sugar with glucometer, because the main idea is that every patient should be screened. She should get the result in that one visit only. And glucometer is the only practical way to really even it is something which is available at doorsteps also. The ASHA workers are taking that glucometer to their homes and doing that test over there. So considering the feasibility, the glucometer testing is very much acceptable, but quality control has to be ensured by following the calibration guidelines for the particular instrument. So the glucometers, when used for screening, they should be calibrated every 20 measurements of blood sugar, and every time a new vial of test strip is opened up, and every time machine suffers a drop. So moving on.
I just, sorry, I just want to say that
yes,
the
ma'am.
patient has to go to the hospital for booking, right? She has to do all other
Yes,
investigations. It's not the blood glucose alone. She has to do her viral markers, her CBC. So we would rather say that she goes to the hospital and gets the venous plasma glucose done. That what I was talking, that was for the monitoring. Once she's on monitoring and self-monitoring. So then
yes,
that periods when in between the lab glucose, I was talking about monitoring, you were talking of diagnosis. So we were slightly on different pages. So I got your point, but we should rather recommend that she go. We don't know the ASHA worker, the glucometer she is carrying, how accurate. In our own wards, we have seen. Sometimes the reading are so erratic, next day you send to the lab and then, you find out. So ideal would be that, yes, but if something is better than nothing, we say, then the capillary one is okay.
At GMC Amritsar, ma'am, when we got the glucometer, our lab technicians just didn't know how to get it started. We had to teach her how to calibrate it. She's a senior technician, she didn't know that. So ultimately, doctors have to learn these tricks also, at least in public health sector.
Right.
Yes, Dr. Vinita.
I wanted to make one. They say presently the glucometers which are coming, the difference is less than earlier. They used to say the value is 10 to 15% higher. Now they say it is just 7%. And somewhere I was listening to Dr. Hema Divakar's lecture. She said that AccuCheck glucometer by Roche, it is recommended by Government of India because it is calibrated and the margin of error is very less for diagnosis, for screening test.
Okay. Yeah, this is what I wanted to bring forth the thing. Nowadays, the glucometers that are available, even with the ASHA workers, they are plasma calibrated. And even the glucose strips, they are also plasma calibrated. So that is why there's not much variance in the levels.
But they should be aware to calibrate them after every 20 readings, as Dr. Suparna told.
But
And
they're
whenever
already
a new vial is started, new strip is
Yeah.
pack is started.
So our patient underwent her DIPSI screening. Her 2-hour post-glucose sugar value was 166 milligram%. We were ready to label her as, we in fact labeled her as a case of GDM, but patients are sometimes not so convinced. So she wanted to go for a more conclusive test, and she was advised WHO 75 gram OGTT, which thankfully confirmed the diagnosis of gestational diabetes mellitus. So what is next for us? I would like my panelists to throw what all they would like to see for in history for this patient in her examination. Dr. Nishu. Dr. Nishi.
Hello. So in this case, like she's third gravida and there is no previous history which tells us that she is a high risk, but we should look for her weight, basal metabolic index. Her prenatal diagnosis is definitely she's hardly 2 months, and definitely HbA1c, which I have already pointed out.
We'll come to other points later. Let's just stick with the history. So in history, once you label a patient as GDM, what in every visit, some questions that need to be asked. Of course, family history and that everything is there.
Is important. Whether her parents' maternal side they are diabetic or
मम्मी दोपहर कितने गई थी? 4
history of birth
4
weight,
बजे तो बाद आई
baby's
है.
birth weight, whether it was more than 4 kg or not, right? And these things are important in her history.
Yeah.
Dr. Suparna, time is over for case 1. Sorry.
Oh, okay, ma'am. I'll just try to speed it up.
Yeah.
In every visit, we have to remember these patients at our higher risk for UTI and lower genital tract infection. So symptoms related to that should be asked for. Symptoms related to preeclampsia have to be asked for, and dietary history. Every time we have to check. First time, of course, we have to ask so that we advise her accordingly when we talk about MNT. But in every visit, we have to check how much she is sticking with our advice. So BMI is important because obesity is an independent risk factor, and for advising for MNT also and weight gain targets, we need her basic BMI, pre-pregnancy BMI, that has to be known. So what about prenatal diagnosis for this patient? She's in first trimester and we have diagnosed her as GDM. So what all tests would you like to go for? Dr. Poonam? Dr. Poonam is not there. Dr. Parneet?
Yes. At 8 weeks, now that she's screened positive, we want to diagnose test. We need a dating
possibility
scan
of
for her.
fetal anomalies. Yeah.
Yes, we need a dating scan for her between 9 and 13 weeks, then a NT scan along with dual markers between 10 to 14 weeks. And of course, then we will go for an anomaly scan between 18 and 22 weeks along with her echo for the baby to rule out any cardiac anomalies, which will be less because it is.
Yes, ma'am. So
it's
this
not a
first
pre-gestational
trimester
diabetes,
screenings. Yeah. These first trimester screenings are advised for every patient nowadays, but in this patient, especially when she is in first trimester, we must not forget her NT scan, her early anomaly scan, as well as 18 to 20 weeks anomaly scan. And of course, if possible, first trimester preeclampsia screening guidelines should also be followed. Yes, role of HbA1c. One thing we understood that we want to see the risk of anomalies, but is repeat HbA1c testing advisable in all trimesters for such patient? Dr. Seema? Okay, Dr. Nishi?
So it gives us 3 months blood sugar test. So once we have done in first trimester, and if the levels are normal and later on we are controlling the blood sugar. So later on the role, I don't think so that it is going to help us. But if we are maintaining only a strict control, but if patient is coming to us in second trimester or third trimester, then 1 or 2 times it is, I think, required.
So, Dr. Vinita, your take on role of HbA1c?
HbA1c is a very important marker for embryopathy. So raised HbA1c levels, if they are present, we can counsel the patient. If HbA1c is less than 6, then she has got a very low risk of congenital anomalies, as equal to the incidence in the normal population. But if it is high, then she stands a high risk for congenital malformation, especially the structural abnormalities. Because as the statistics say, if HbA1c is more than 9.5, the risk of malformation increases to 22%. See, it is not important to do HbA1c here for monitoring glycemic control because the whole RBC kinetics is changed in pregnancy. The red cell turnover is increased, and there is secondly hemodilution of pregnancy. So HbA1c, if we say it is not to be used for monitoring the blood glucose levels, but basically for seeing the blood sugar as a marker for embryopathy, and also to predict whether these pregnant ladies later on will have high risk for large for gestational age babies, for macrosomia, for polyhydramnios, or other adverse events.
Yeah, so very rightly said, HbA1c should be used only as a prognostic method, not as a diagnostic test. If HbA1c is less than 6, you don't say that you are not having gestational diabetes. That is only based on our glucose challenge test, and it is not a test for monitoring glycemic control. For that also, we need postprandial sugar levels. So, okay, MNT has been discussed in so nice details by Dr. Ragini that we don't have to go for that. And can someone please describe this thali for a pregnant woman? Very nice thali given in Government of India guidelines. Dr. Nishi, can you do that?
Yes. In this thali, first it is a very decorative thali, looking nice. So we should give at least 40% of carbohydrates, right? And that carbohydrates also should be complex carbohydrates. Like we can tell them to have besan, or you can have ragi, jowar, different types of food, right? And then around this more protein, it should carry more protein and 20 to 25% of fats. And fats should not be saturated fats. Like again in Punjab, we are taking a lot of makhan and other things, right? So that quantity also should be less, and with fiber. That is also very, very important for this thali. So if we are advising, and more, another thing I would like to add, like I am asking my patient, first I take their history, what they are taking in breakfast, what they are taking in lunch, and what they are taking in dinner. From there, I try to advise them that what all things they should have in their diet. So that is how MNT can help.
Yeah, that's why the initial dietary history is so important. So at least half of the thali should be taken up by vegetables. 1/4 of the thali should be occupied by cereals, complex carbohydrate, and another 1/4 reserved for purely protein-rich fruits. Dairy products should be there, but as Dr. Manjeet correctly pointed out, we have to take out the cream part from that, and 1 serving of fruit, which should not be banana or guava for these patients, for banana or grapes for our patient. The fruits with low glycemic index, that is what we would like to advise. So, counseling for physical activity, Dr. Vinita, what all advice would you like to give to your diabetic patient?
See, MNT has to be supplemented with physical activity. So we advise the ladies approximately 30 minutes of physical activity. They can just stroll or walk, or even like just Dr. Ragini said, it can be split also, 10 minutes, 3 times a day. And if the lady finds it difficult to move, maybe because of other factors like edema or body weight, then even simply she can sit and do arm movements, leg movements. And
absolutely right. Thank you for highlighting that, because many of our diabetic women, at least later in the pregnancy, some of them will be having polyhydramnios, or some of them will be having problems like threatened preterm labor. And on one hand, we are advising them rest in other population, but what to do in diabetic patients? So arm exercises after meals are an option available for us. What should be the ideal weight gain due?
Dr. Suparna?
Yes, ma'am.
So it's not so much required that she does this 30 minutes of exercise daily. She can just go for 5 days a week. So 150 minutes of exercise per week is sufficient. So she can have 2 days of relaxation as well. She'll be happy if we tell her that. So
ma'am, it's the over-relaxed society which has led to this problem. I would tell her do it every 7 days. Only then she's going to do it 5 out of 7 days.
Yeah, then she will do it. That's true. We are just talking about the theoretical
Even simply if we say her to stroll for 10 to 15 minutes after each meal, that will also serve the purpose.
Yes.
Absolutely.
One more thing,
Dr.
Dr.
Seema, what about
Yeah,
what
can
should be
I?
our advice for weight gain during pregnancy for a diabetic patient?
Yeah. So if the patient is having a BMI, which is the ideal BMI, 18 to 25, then she can have a weight gain of 12 kg, 10 to 12, 13 kg. But if she's obese patient, like I would say really obese patient, then her weight gain in pregnancy should be really half of that. So that way the weight gain increases or decreases. If somebody is malnourished, she is underweight according to her BMI, then she needs to gain more weight and she is allowed to consume more calories. Calories and weight gain, everything correlates with the BMI of the patient. So we have to calculate her BMI and then to tell her this is the weight gain that you are expected to have and this is your calorie intake per kg of ideal body weight. So according to that it goes.
As care providers, we need to be aware of the weight gain per week. So our normal weight patient, we are thinking about 400 to 500 gram per week. That is good. But for overweight patient, we have to counsel her. It should be less than 300 gram. For our obese patient, it should be somewhere around 200 gram per week. With this practical approach, we will keep on giving her feedback how well she is doing in her MNT as far as weight gain is concerned. Okay, anything else in counseling anyone would like to add? Counseling of a GDM patient.
We have to keep them motivated. So that is to
Yeah.
have a positive spirit that if you do it the correct way, if you follow the instructions, you're going to have a good outcome. So it's just a matter of time so that she doesn't feel low and everything. So we have to keep her up the positive spirits during every visit. That is also our duty because otherwise they are likely to go into stress and depression and all.
And these patients are going to have more chances of PIH. So hypertension also should be taken care of side by side. Because this fear should also be enlightened in their mind that if they are not going to control, so this can also come.
One more
especially
counseling,
with diet, especially with diet, we have to tell them about macrosomia. If they are overeating, it's going to be a big baby, but that not going to be of good outcome. So we have to explain her that diet is also going to correlate with all that. The weight gain is also going to correlate with macrosomia. So that way she will understand better the importance of everything.
In that also, Dr. Suparna, I mainly stress on that they should go for seasonable vegetables and fruits and
Yes,
not
ma'am.
canned juices especially. And
Absolutely right, ma'am. Absolutely right.
And
So,
that will add to the fiber and control of hyperglycemia.
Yes, ma'am.
For
Yes,
diet,
ma'am.
one thing has to be made very clear to the patients, the general dictum is that eat like a king, for the breakfast, and for lunch, dinner, eat like a prince, and then for dinner, you eat like a pauper. But here it has to be the other way. The breakfast should comprise only 10% of the calorie requirement, and then rest 30% for lunch and dinner, and rest 30% for intermediate, snacks. So breakfast is not going to be heavy. It has to be only 10% of the total requirement.
I also second what Dr. Vinita has said because the insulin resistance is high at that time, cortisol levels are high. So carbohydrate intake has to be less. People take a lot of carbohydrates in the breakfast time. So that has to be really curtailed.
Yeah, that's right, ma'am. So basically, the first diagnosis of GDM, it's all about counseling and counseling and counseling. We have to, on one hand, scare them that don't take this lightly. On the other hand, we have to give them hope that if you are capable of reaching the euglycemia with these lifestyle changes, then your baby can have as healthy an outcome as any non-diabetic female. And we really need to highlight the long-term effects on their own health and on the health of the fetus also at the time of counseling. So all this thing, and of course we have to teach them home-based glucose testing, the target glucose levels that have to be taught, and a need for frequent hospital visit. They cannot just come like a low risk pregnancy to us, coming just once in 2 months, once in 3 months. That won't be acceptable in this case. So one more question was, would you like to start aspirin in this patient? Dr. Paneet.
In this particular patient, we don't know her BMI, what is it, or any previous uneventful pregnancies. So if there is a risk factor, definitely we have to start with aspirin. But as such, till the history we know, I don't think so. I will start aspirin in this patient.
Okay, great. So we have this gestosis score available with us. Gestational diabetes mellitus carries a score of 2. We need 3 to start ecosprin. So if we have anything from the left side
Added to that.
available to add on to this 2, then this patient is a candidate for starting ecosprin for prophylaxis against development of preeclampsia.
Preeclampsia.
Moving on, we have started this patient on MNT. How do you follow this patient, Dr. Nishi?
So as already Ma'am Ragini has explained everything about MNT, so we first follow with all the things and all the guidelines according to that. And this we do for at least 15 days. And if he is able to control the MNT with this diet, then we continue with MNT. But if not so, then we switch over to the pharmacotherapy. So
yeah, so we call her after 2 weeks for repeat postprandial sugar testing, and our target is of course 120. We have to teach these targets to our patient, but in every visit we have to be watchful for development of preeclampsia. What about fetal surveillances? If everything is going on normal, if there is no need for adding insulin or metformin, would you like to put this patient on serial growth scans? Is there any need for additional antepartum fetal surveillance, Dr. Seema?
Yes, there is requirement of additional antepartum surveillance, definitely. So one is we have done the NT scan, then we have done a level 2 scan. After that, we have to do a scan at 28 weeks. Then somewhere around 34 weeks also, we have to do serial growth scans. So the thing is, if the AC at any time is more than 75th percentile, so we know that this baby is going into macrosomia, or the AC is more than 90th percentile. So we know now this is, it is MNT won't be sufficient. We have to intervene now. And antepartum fetal surveillance so that we can give her a good outcome. After 32 weeks, we have to do NST bi-weekly. Ideally, biophysical profile also twice weekly, but in low resource settings, even if we do once a week, so that is sufficient. So you have to keep her monitoring. And then eventually you have to take her to a gestation where the lung maturity has been attained. So we have a long way to go. Let's say from 32 when we start till 39 weeks, that was reasonably long way. So under surveillance itself, we have to carry her pregnancy till term.
Thank you so much, Dr. Seema, because most of the guidelines, the Western guidelines, they are saying that there is, many of them are saying that there is no need for additional antepartum fetal surveillance if the glycemic controls are met. But in practice, I think once we have labeled the patient as GDM, she is a high risk pregnancy, and we are really, really bothered about fetal well being. So I think all of us are doing that. The growth scans, the bi-weekly NSTs in third trimester. If there is any different point of view, please anyone should enlighten us about the same.
Yeah, and one very simple way for fetal surveillance is to teach them DFMC,
Yeah, absolutely right.
Babies
Yeah,
can do on
absolutely right.
their own, teach them. And, after meals, we ask them to lie in the left lateral position for 2 hours. And if they are able to perceive 10 movements, then we say for at least 24 hours, your baby is okay. So they can do this at home.
And
Okay,
this
we already know.
unexplained stillbirths can occur in gestational diabetes. That is the reason we are doing, so much of antepartum surveillance. And as we have said about MLT also, if you explain the patient to do it twice a week, she will only turn up once a week. So,
Yeah,
they will do much
that's
less than
absolutely
what
right,
you
ma'am.
explain to her. They will do anyway less than that. So,
Somewhere we have all experienced one such mishap, even in a well controlled patient. So we are always on our guard in a GDM patient. Need for pharmacotherapy, of course, when glycemic indexes are targets are not met. We'll discuss that in the context of our case too. But just before moving on, when do you terminate this pregnancy? GDM on MNT, no pharmacotherapy being given, well controlled. Dr. Paneet.
39 to 40
this
weeks.
patient is GDM and she is controlled on MNT.
Yes,
Her
ma'am.
postprandial blood sugars are below
Yes,
1.
ma'am.
So we can take no induction to be done before 39 weeks. So most of the guidelines say that they say between 39 to 41 weeks, but we hardly go beyond 40 weeks. So beyond 39 weeks, I would like to induce the patient and deliver her according to her. Maybe
So we agree on that 39 to 40 weeks as far as patient is on MNT. But if she is controlled on drugs, would we like to prepone the time of delivery? Dr. Seema, what is your take on that?
Definitely.
Definitely, the
Definitely.
apprehension is rising in the mind of the obstetrician as well as the patient. So if we don't take her to 40 weeks and induce her at 38 weeks or 39 weeks, I think that should be good enough, even though the control has been good, but she has been on medication and, additional responsibility on us also. So we can,
absolutely
discuss
right.
with the
37 to
neonatologist.
38 weeks.
Yeah, but little bit of
Yeah.
thing, I think TTN is one thing. Little bit of transient tachypnea of newborn can occur at 38 weeks, even though like that proper ARDS won't be there or HMD won't be there, but TTN we have to be aware of, discuss with the neonatologist,
But
and then take
we are always more worried about the stillbirth than TTN, right? So yes, on drug therapy, maybe earlier than 39, 38 to 39, maybe that is where we settle down for this patient. But ultimately, patient must be involved in decision making. It should always be a shared decision making. If we are going to wait for another week, she should be on the same thought process as we are. If she has her doubts, we have to appreciate her apprehensions also. So, take home messages from case one: universal screening, early screening. One screen positive, be clear in your counseling and advice. Don't keep changing the diagnosis because another test says something else. MNT plus exercise, it has to be individualized, it has to be reinforced in each and every visit. Surveillance should be like a high risk pregnancy, and 2 weekly or weekly monitoring for postprandial glycemic control, and no need for termination before 39 weeks if patient is well controlled on MNT and there is no visible complication. Coming to case 2, now she's a 29-year-old weighing 70 kg, BMI 31 kg per square centimeter, G4 P1 L0, 2 abortions, and presently she's at 27 weeks estimated gestational age, and she's coming to us for the first time because Asha worker has referred her because of her obesity and previous 2 pregnancy losses. Her past history is suggestive of PCOD. Then she had secondary infertility. Previous 2 abortions were both spontaneous and were at 2 months and 2.5 months period respectively. And when she came, we of course went for the glucose challenge test. Now this is a 75-gram glucose challenge test, fasting sugar 110, 1 hour 224, and 2-hour glucose 209 milligram percent. Dr. Paneet, would you label it as gestational diabetes?
It will be gestational diabetes mellitus only because this is the first time that we are seeing her abnormal sugar levels. So it is gestational diabetes mellitus only. But in this case, here comes the role of diabetologist as well as nutritionist, because we have to, because the levels are gone above 200, so we will have to start. Of course, we will explain her MNT, but we will have to start with pharmacotherapy. So we will need an
Dr. Seema.
endocrinologist to advise us.
Yes, ma'am. Dr. Seema, would you label her as gestational diabetes?
Theoretically, yes, as it is first recognized during pregnancy. That is just the theory part. But her post-glucose 2 hour is 209. So at any time when post-glucose 2 hour is more than 200, she is overt diabetic.
Overt diabetes, yes.
She's overt diabetic because, and also look at her background history, her BMI, her PCOD. She has all the background for having overt diabetes. So it is going more in favor of, by that criteria of fasting, 126 is not there, but post glucose 2 hour 209 puts her in the category of that.
Yeah, so basically it is for cases like this that WHO and FIGO are now giving us 2 terminologies. One is gestational diabetes and one is diabetes in pregnancy. Diabetes in pregnancy is when pregnancy is happening in a previously known diabetes, or when hyperglycemia is diagnosed for the first time during pregnancy, but at the time of diagnosis itself it meets the WHO criteria for diabetes mellitus in non-pregnant state. That means fasting sugar more than 126, any random sugar more than 200, and this post 75-gram glucose challenge, two hourly sugar, that when it goes beyond 200 they are labeling it as diabetes in pregnancy. But as of now, even after I guess 10 years of these guidelines in India, perhaps most of the places we are still sticking with the diagnosis of gestational diabetes when it is first diagnosed in the pregnancy. But I think for our data to be comparable internationally, we need to change, to be ready to change our labels now for such pregnancies. And for that, I would like request Dr. Pani to highlight how is our case 1, Mrs. X, different from case 2, Mrs. Y, in terms of the prognosis for the fetus and in fact also for the mother.
So it is definitely case 2 is she is in much trouble, because in case 1 she had her first visit in first trimester, and it was very early pregnancy, and we diagnosed her, so we can advise her, we can look at the prognosis of the mother and the fetus, and we can counsel her regarding more frequent visits and what need to be done for her, and we have much time for her to take counsel her regarding her pregnancy. But here we are more worried because she's already having no live issue. She's already almost into her third trimester of pregnancy and very bad blood glucose levels. So much needs to be done for this patient, and definitely prognosis for mother as well as the fetus is very bad until we take much care for her. She needs admission, she needs counseling, she needs to be started on pharmacotherapy and strict vigilance for the fetus as well. So
Great.
with proper
Dr.
growth
Vinita.
scan and starting of pharmacotherapy.
Yes, ma'am. Dr. Vinita, would you like to add something?
Yeah, on the same question itself regarding the prognosis,
same question.
Pharmacotherapy. Yeah. See, we have to consider a few things. Here, this patient, Mrs. Y, she had adverse obstetric events, She had 2 abortions, no live issue, antecedent history of PCOD, treated for secondary infertility. Her BMI is high, weight more than 70 kg, I think it was mentioned. And Mrs. X, her BMI was normal. She did not have any adverse obstetrical outcome. Her blood sugar levels were in the insulin tolerance, glucose intolerance range. And here, for Mrs. Y, they were in the definitely in the diabetic range. So she has already crossed the period of organogenesis. So we have to evaluate her. We have to get a detailed anomaly scan to see for any structural abnormalities which are specific to diabetes. So the fetus has, sustained that hyperglycemic insult. So if the fetus is at lurking danger for stillbirths again, or if the fetus has already developed macrosomia or polyhydramnios, or the mother has, already developed any kind of vasculopathy in terms of retinopathy, nephropathy, or proteinuria, or other complications, then these add to, worsening of prognosis for the fetus, because the fetus is subjected to more of hypoxia here. So we have to monitor Mrs. Y for all the events of all the effects of vasculopathy. We have to do a retinal examination. We have to get her serum creatinine levels, urine for proteinuria, and she has to be started immediately on insulin. So
so we don't really know for how many years she may be harboring this disease. So the microvascular damage may already have been done. So investigating this patient should begin with all this, looking for features of nephropathy, retinopathy. We have to consider the maternal well-being as such also in this patient, and of course evaluation for fetal anomalies at 27 weeks. Still we have the option of for going for a level 2 scan, at least giving her a realistic picture what she can expect as the pregnancy outcome in terms of an anomalous fetus. So as Dr. Paneet has clearly highlighted, this is not a case which will be managed only by MNT. It has to be MNT plus pharmacotherapy. Let's come to pharmacotherapy. OHAs, what is the role for OHAs in this pregnancy? Dr. Nishi.
So in this
Dr.
case,
Suparna, can you please wind it up?
Yes, ma'am. Yes,
Another
ma'am.
5
I'll
minutes,
just
please.
give me 5 more minutes, please.
Yeah, sure.
So in this case, we have to put the patient directly on insulin, because even metformin is also going to take time to control the blood sugars, right? So plain insulin along with intermediate acting insulin is the answer for this patient. Strict control, hospitalization, monitoring of the blood sugar very frequently, 7 times sugar.
What if your patient says no for insulin?
So
What if
then
your patient
there is
says
no
no, sir?
choice except for explaining the patient the high risk. Then we put the patient on metformin, diet therapy, exercise. That is the thing we can advise her. But along with that, explaining her the risk of high blood sugars.
So there was a time when we said metformin is
Yes.
contraindicated in pregnancies. It's no more contraindicated. It is an acceptable alternative to insulin, which is definitely the drug of choice. Glyburide, no, glyburide is definitely giving inferior results than metformin, so it has to be metformin. Coming to insulin therapy, Dr. Seema, which insulin?
There are three types of insulin. There's rapidly acting insulin like Lispro and Aspart. Then there's short acting, that is regular or soluble insulin is there. Then there's NPH insulin, which is intermediate acting, and there are long acting insulins like Lentus and Altimir. All these can be given in pregnancy. So depending upon the requirement, we can adjust. Either I think first we start on regular insulin. Now, the dose calculation depends upon the body weight of the patient first thing, then the trimester of the patient. So we calculate the doses like it's 0.7 unit per kg in first trimester, 0.8 unit per kg in second, 0.9 unit per kg in third trimester, and 1 unit per kg at term. So we find out the dose, start her on regular insulin 3 times a day, and nighttime NPH if the patient's fasting blood glucose is high. Then eventually, to make life simpler for her and for ourselves also, we would go for mixed start, which is a combination of NPH and short acting, that is the regular insulin. So 2/3 and 1/3 we go, and then we titrate and fix the dose, and then we keep on monitoring that.
Absolutely. So, and role of endocrinologist, role of physician, we all agree on. But ultimately, this patient is our patient. Every week she's coming to us, and physicians, they do not deal with the diabetes in pregnancy or gestational diabetes in the way that we do. I think the difference in management is just like the difference between a surgeon doing a hysterectomy and a gynecologist doing hysterectomy.
I will like to add one thing. My husband is
Yes,
a
ma'am. Please
physician.
do. Please do.
My husband, I used to tell him that bring the blood sugar down to 140 initially when it was 140. He used to say 160 is okay, no problem. You manage her according
Absolutely.
to
Absolutely right, ma'am. My husband is also a physician, so I'm giving this feedback. It's the same here. They say it's okay, it's okay. We know this is not the target that we want to achieve. Dr. Vineet, you would like to add anything? Your choice of insulin.
I would like to split it into, basal and bolus insulin.
Yeah.
So initially, like here, the sugar levels are very high, more than 200. So I would like to give a combination, mixed out insulin, a combination of regular and NPH in the ratio of 30 to 70. And usually, I like to take an endocrinologist opinion. But if not available, then we calculate, as Dr. Seema said, we calculate the total requirement. And to start with, we divide it, morning dose 2/3 and night dose as 1/3. And I also like to do, midnight levels of blood sugar so that, patient does not have early morning, midnight hypoglycemia, the sugar levels should not go down below 70 because hypoglycemia is more dangerous than hyperglycemia. So we have to see that, and accordingly we adjust the dose of intermediate and regular insulin that way also. So as a rough guide, we see that if the blood sugar levels are between 120 to 160, the dose of insulin is 4 units. And if it is between 160 to 200, 6 units, and more than 200, 8 units. It is initially we started giving it as 30 minutes before breakfast once a day, and later on as pregnancy advances and insulin resistance is increasing, then we like to titrate the dose with evening night pre-dinner dose and pre-breakfast dose. So if we find pre-breakfast levels or fasting levels, they are high, then the nighttime dose has to be increased. If we find that postprandial levels are high, then definitely we would like to increase the dose, morning breakfast dose. And we keep on increasing in units by 2 units till we get a euglycemic control. Like we say, fasting blood sugar should be less than 95 and postprandial less than 125. And once this control is achieved, then we follow this and keep on doing blood sugar levels every third day.
Great. So we can just go on talking about insulin, but we don't have the time available. Hypoglycemia, features of hypoglycemia, management of hypoglycemia must be taught to a patient who is being started on insulin, to her family, in fact. What to do, the home remedies that are available, they must be taught. Moving on, frequency of glucose monitoring, 7 times testing or 4 time testing. Dr. Seema. Your mic, ma'am. You're muted.
Sorry, sorry. Yeah. So if she's on oral hypoglycemics, then we can go for 4 times testing. That is fasting and PPBS, breakfast, lunch, dinner. But if she's on insulin, then 7 times is recommended. So that is the information.
Dr. Nishi. So for starting the insulin therapy, for setting the dose, 7 time
Yes.
testing definitely
So
is
after
required. But
that,
once she is
afterwards,
settled, we can
yes.
decrease the testing, relying more on our fasting and postprandial testing. Fetal surveillance is, I guess, the same. I would just like take from Dr. Paneet, what are the predictors of risk of stillbirth?
if her sugar levels are not controlled, basically, so that is why we strive for strict sugar control. So that is one thing, because it will lead to because still, and that is why we need fetal surveillance, so that
Absolutely
we are
right.
more concerned for that. That is why we explain the patient DFMC, and we go for bi-weekly NST. That is the one reason.
Yes.
And if sugar levels are not controlled, properly controlled, that is why we think of early termination of pregnancy, because we are concerned for unexplained stillbirth. In controlled blood sugar levels, stillbirth is less often to occur. It is only in uncontrolled, where the sugar levels are not controlled, that we are more concerned about the unexplained stillbirth in the baby.
Yes, also both FGR and macrosomia. Either ends of the spectrum, they are also a risk factor for stillbirth. Presence of preeclampsia is, of course, an indication for early termination. And if the glycemic control was bad early in the pregnancy, even that is a predictor. Although it may be very well controlled now with all the medication we are giving, but if the control was bad early on, then also it is a predictor for and prenatal corticosteroids when indicated, yes or no?
Yes, they should be given, but then we have to be very vigilant that the sugar levels will be disturbed for the next 2 to 4 days. And we may also
Absolutely
really
right.
need to increase the dose of insulin as well. But if they are indicated, we should give them.
Yes,
for the
but that
sake
should
of
always be in hospitalized
in
condition, not
hospital.
on OPD
Yes.
basis. So when to terminate, how to terminate, when to terminate, I think the same criteria can be followed here also. But what about the mode of termination? How many of you, just this is the last question, how many of you agree with this flow chart? Do you wait for a cutoff for 4 kg for going for an elective cesarean, or maybe lesser?
I would rather go for lesser, because see, the foreign criteria, they're different from Indian standards, right? So if we go by Meherban Singh charts, right? So at that, maybe more than 3.7 kg is LG at 40 weeks. So for Indian women, so when it is surging 3.8 kg and all, we would be really concerned about shoulder dystocia, development of cephalohematoma, fetal distress in second stage. At that time, you can't undo when there is shoulder dystocia. So you should rather take for cesarean section when it is around 3.8. We won't go for 4 and 4.5 kg, not for Indian standards.
Absolutely. Dr. Nishi, your cutoff for elective cesarean.
3.5 to 3.7 in between.
Okay. Dr. Paneet.
Same. Above 3.5, anything else. So it is.
Yeah.
So patient
It is not 4 kg at all.
It afraids us when we see the weight more than 3.5.
And in this particular patient, there are so many other factors which will go more in
Absolutely right,
favor.
madam.
She is having bad obstetrical history, no alive issue. She is having obesity, high BMI.
Yeah. I'm just skipping the remaining part
After
because we are already out of time. But this patient needs postpartum care also in terms of the surveillance, repeat testing at 6 weeks, follow up for I actually labeling her as diabetes, and her future pregnancy should always be planned. And if there is no plan, there should never be an unplanned pregnancy. So the take home message is we have to be responsible in terms that we have to screen every pregnancy. We have to be realistic. When it is a case of bad glycemic control, we have to give the true picture and not give false promises to the patient that this report is fine, that report is fine. But we have to be optimistic. We have to tell them that we are there for you as far as it is possible. We would like to optimize your outcome, and we have to remain really vigilant throughout the pregnancy, because if once a diabetic patient is in third trimester, obstetrician should not be getting good night's sleep. That much should be our vigilance. So that is all for this panel. I would like to thank all my panelists for their great inputs and insights. And in my checklist, only one thing is left: to thank Dr. Madhu and Dr. Kavita for giving us this opportunity. Thank you
Yes.
so much.
Wonderful webinar.
Sorry for exceeding the time limit.
So we had great exchange of views and it was a good webinar. Thank you. Thank you, everyone.
Thank you so
Thank
much.
you,
I
thank
would have loved to hear more and more, but the time limit has been crossed. So I was told
Absolutely.
to cut short the panel discussion. And I think
Yes,
it
ma'am.
was a brilliant discussion from all the panelists and the moderator. And in the end, I would like to propose a vote of thanks. On behalf of Punjab chapter NIGF, I want to thank our special chief guest for the occasion that we had, Dr. Sharda Jain ma'am, Dr. Sadhana Gupta ma'am, and they have very kindly accepted the our invitation, and they have graced the occasion in spite of the very busy schedules. And we had an opportunity to hear from them their thoughts and their very inspiring messages, and this will surely encourage us in our future events. We are very grateful to Dr. Amritpal Kaur. She is the Vice President of NIGF, for accepting our invitation, gracing the occasion. And we are also want to extend a heartfelt thanks to our speakers, Dr. Manjeet Mohin, Dr. Ragni Agarwal, to our chairpersons, Dr. Ruby Bhatia, Dr. Aruna Chaparia, Dr. Surjit Kaur, and Dr. Anita Rajoria, and who else? I've forgotten the names of the chairpersons at the fag end of the day. But all the panelists and the moderators for a very insightful, knowledgeable talks and panel discussions. And my very, very special thanks and deepest gratitude to the President of Punjab NIGF, Dr. Madhu Nagpal ma'am, and Dr. Sushma Chawla ma'am. She is the Vice President of Punjab NIGF, and ma'am was very busy. Dr. Sushma Chawla, she had actually told me that she will not be able to join, but ma'am has been so kind enough to sit throughout the event. From the beginning, she joined till the end. And without Dr. Madhu Nagpal, Dr. Sushma Chawla, who are the pillars of Punjab NIGF, this event would not have been possible, and we will not be able to move forward. So we look forward to your continuous blessings and support, ma'am, throughout in our future endeavors. And I'm also thankful to all the Punjab NIGF office bearers. We have Dr. Suparna Grover, Dr. Parneet Kaur, Dr. H.K. Chima, Dr. Ripin Bala, and Dr. Seema Grover Bhatti, and they have accepted to be the office executive members. And I look forward to your support, and let us work together in our future, whatever we plan, academic events, maybe it may be on site or online. So I look forward to that. And in the end, I also want to extend a heartfelt thanks to all the audience for attending this event. That was the inaugural webinar of Punjab NIGF chapter. A final vote of thanks to Corona Remedies, the IT team, for giving us the platform and for the smooth conduct of the webinar. I hope I've not missed anyway. Dr. Ruby Bhatia, ma'am, I forgot to mention. Ma'am is also here. So thank you so
And
much.
thanks to you, Dr. Kavita, for organizing
here.
everything, for planning everything, and for bringing us all on this wonderful platform.
Yeah, let us be together in future also. Look forward to it. Thank you, ma'am.
Thank you, Dr. Kavita. Thank you so much. Thank you.
Okay, bye-bye.